So I'm going to start the live now.
Okay, shall I start?
Yes.
Good morning to all of you and wishing you a very happy Vishu in advance. So TACO has been conducting a yearly PG update, but last time we were not able to do this because of COVID. So this time we are on a virtual platform. Hopefully next year we'll go back to a physical if COVID allows us. So welcome to all the PGs who have joined us and to all the other faculty who have also joined us. Today we have two renowned faculties. Actually for radiological imaging is a puzzle for all of us. So it is very nice to have with us Dr. Sandhya from Amrita Institute of Medical Sciences, Associate Professor, who will be guiding us through the CT and MRI. And of course, Dr. Ani, our own TACO member, who's going to present the practical aspects and who's going to chair the session. Thank you both for joining us. And I'd like to specifically thank all of those who have joined and who are going to present here, all the PGs, as well as most importantly, our coordinators here, Dr. Baston and Dr. Tanushri, for being here to help us out on the Zoom platform. This whole program has been conceived by our Vice President, Dr. Mallika, and our Secretary, Dr. Sujata. So over to Dr. Mallika for giving us an overview about it.
Thank you, Dr. Sudha, and very good morning, all of you. Actually, I'm very happy to share this platform today because the two speakers today, Dr. Sandhya and Dr. Ani Sridhar, I'm very closely related to them. Both of them were my classmates and my roommates. Dr. Ani as my senior and Dr. Sandhya, my own roommate, my own classmate. And we used to study together. And so when Sudha and Sujata proposed this PG update, I had no doubt. It was Sandhya as the first choice, as the teacher for teaching our PGs the imaging in ophthalmology. And when I approached her, she readily consented to present this. And from the very beginning, she had been a very good teacher. She used to teach me anatomy. We used to study together. And she did her MBBS from Government Medical College, Thrissur, did her post-graduation from SN Medical College, Jodhpur. And since the last 13 years, she has been working in Amrita Institute of Medical Sciences. She is a very good teacher. And still, not only that, she is a very good art of living teacher as well. I am her disciple. She had done the teaching for more than 100 people all over Kerala, and deeply indebted to her for that. And for Dr. Ani also, she is also a very good teacher, very good academician, we all know. And Dr. Sandhya has got, her specialty is head and neck imaging, and she has got some 15 to 20 national level papers. And I'm very sure you all PGs and all of us will be really benefited by today's teaching and sharing of their experiences. Thank you so much.
Thank you. Good morning, everyone. I'm so happy to be here today. I'm with this all renowned speakers, two renowned speakers. Most interesting thing is that both are Thrissur people. Both are, as Malika said, are from Thrissur Medical College alumni. And now I think we don't need to go in detail about introduction of Dr. Ani Sridhar because she's one among us. She's a TACO member. And we all know that she's a very renowned oculoplastic surgeon and has references from all over Kerala at least. I don't know about that. And as Sudha said, it's a very informal meeting. I did not collect her number of publications, but I'm sure that it is numerous. And most important thing is that she was always there to help us when we had some problems or some doubts. And so I am sure, and she also helped in conceiving the part of program today. So today's program, this workshop is conceived from the viewpoint of the PGs. This how it will be, how they can, if postgraduate student can understand the ocular imaging. And so Dr. Sandhya will be talking about the basic aspects of how to read or approach these images, and also certain second session, more practical clinical scenario based discussion. And third session, Dr. Annie Sridhar, as she's already said, you cannot diagnose with the image. You need clinical correlation. So she will help us in clinical correlation with images. And dear PGs, after this, I believe that you will not run away from seeing these images, and you will not ask always, show me the report. So I am sure that after this, everyone of us will gain something and will be very confident. So first, we have introduced our speakers. Now I will ask the presenting PGs to self-introduce. After that, I will ask Dr. Annie to start the session with chair the session. So the presenting PGs, please unmute and just introduce. Dr. Anita.
Good morning. I'm Dr. Anita. I'm a second year junior resident in Government Medical College, Thrissur. I'll be presenting a case today.
Hello, good morning all. I'm Dr. Lakshmi, student of Government Medical College, Thrissur, Department of Ophthalmology, and I'm here to present a case today.
Jessina.
Dr. Jessina has some trouble logging in, ma'am.
Okay, then we can start the session now. Dr. Annie, please chair the session. Dr. Sandhya, you can start presentation.
It's okay. Can I start?
Yeah, please.
So I'm very happy to be with the Thrissur people. After a long time, actually coming in close relation with you. And I thank all the organizers, Dr. Mallika, Dr. Sujata, Sudha, Annie, for inviting me for this session. I'll try to keep it as simple as possible. I'll not go in deep into the details of the physics and all. I'll just tell you how the images are being taken and how to read the things. So I'll share my this thing first. One second. Hope you can see the slides, no? Somebody answer.
Yes, ma'am, we can see the slide.
Yeah. So the three modalities which we routinely use in imaging are, CT scan, MRI, and ultrasound. And CT scan is the most widely used one. And the whole purpose of imaging is you have to locate the lesion where it is, and you have to identify its extension, and also in the post-treatment follow-up, how far it has regressed. So first we'll start with the CT. each modalities works on different principle. Actually, the CT is based on X-ray. So you know, X-ray is an ionizing radiation. So when we take a routine X-ray, what happens? The X-ray is being produced from an X-ray tube. It comes out and it covers the whole body like a fan. But in CT, the same X-ray is coming like a knife. What to say? It is slicing through the body. If one thin beam comes, it parts through one thin section. Then again, the tube moves to a different, and it is slicing the next thing. So you are getting many slices of the body. And we can slice in many ways. We can slice in the axial plane, or we can slice in the coronal plane parallel to a coronal suture. We can slice parallel to the sagittal suture. So even oblique slices also can be taken nowadays. So we are getting slices from, we can slice it in all 3D dimension, and all the images together we are reading to get a diagnosis. So this is something like there will be a gantry in which there will be an X-ray tube, and opposite to that, you see, these are the detectors. And this is the table in which the patient lies. And from the tube, the X-rays come out. It will pass through the body, and whatever thing that passes through the body is captured by the detector panel. So when the X-ray passes through the body, some of it will be absorbed. So some parts will allow it to pass easily, some parts will obstruct it. So the amount of X-rays which comes out will be varying depending on the tissue through which it passes. And unlike the previous machines where we, in the initial era, we were actually slicing through the body, like we'll be taking a 10 millimeter thick slices. Nowadays, what we do is we take a volume imaging. The whole area, if you want to study the orbit, means the whole brain and orbit phase, the whole area is taken as a volume. And later on, after acquiring, the machine will slice it. So you can slice it into any size thickness, means you can take 10 millimeter, 2 millimeter, 1 millimeter. But previously it was not possible. If you have set the machine for 10 millimeters, means only 10 millimeter sections will be available. Now it is different. You can do whatever is possible with the machine, and you need not position the, initially we have to position the patient in various ways to get the coronal and sagittal images. Now that is not needed. Patient can lie very comfortably on the table like this, and after acquiring that volume, that can be sliced in any ways. We can slice it in the axial, coronal, sagittal, oblique images can be acquired. And the difference with the previous thing is the imaging has become very fast. Previously, for one rotation, it was taking about 1 minute for the tube to go around. Now, just sub-millimeter, means less than 1 second, within some 30 milliseconds, the whole tube can go around and acquire an image. So you can understand that it has become so fast, within split of a second, the imaging will be over. And later, the computer will reconstruct the images in various planes. So once you see the image, certain, when you get a film, first I'll tell you how the images come. So when the X-ray pass through the body, you can see there are varying tissues. Now, when you take an orbit, you can see there will be areas of fat, water density, there will be thick soft tissue, bones. So all these structures will allow the X-ray to pass to varying extent. Means a bone or a calcium, if it is there, it will obstruct the X-ray to the largest extent. If there is a metal, it's totally gone. Then if air is there, it will allow it to pass very freely because it is least dense. The fat next, the water next, then comes the soft tissue. So based on the amount of X-ray which comes out, that is quantified and that is converted to an image. If it is allowing much of the X-ray photons to go through, that area will become very dark. You can see in this image, here this is the ethmoid sinus that is filled with air, no? So air will not give any resistance to the passage of X-rays. The whole thing will come out. So those areas will be dark. And this is the fat. You can see the orbital fat here. I hope you can see this. No? So this is the fat, retrobulbar fat. That region also will allow, but not to the extent of air. So that will be slightly less dark than the air. Then when you come to the water, that is the thing, water, CSF, and this aqueous and vitreous, that thing is the next thing. That can resist to slightly more extent than fat. So that will be slightly less dark. Then later on, the soft tissues, you can see the brain matter, that to much more extent, it will obstruct the X-rays. So the amount that is coming out will be less, that will be looking more gray. So you're getting a varying grades of shades of gray for the soft tissues. And when you look at the bone, you see the bone will be totally obstructing. Bone, any calcifications or any metal is there, it will be totally obstructing, that region will be appearing white. So when you see a CT image, first you just look at the bony calvaria. Any image, you look at the calvaria. If the calvaria is white, that is a CT image. In MR image, this bony calvaria will be always dark. So this is one way you can differentiate a CT from an MR image. Okay. Then the next thing we have to see is, when you get an image, there will be some hundreds of images taken because we are slicing through the whole body, you know. So each image is important. You can't leave out one image and go to the other. You may miss something. So every image you have to look meticulously. So first thing is, when you look at an image, in one corner you can see this writing. Here you can see the name. This is the name, Mr. XYZ. They'll be putting the name here. Then the age, sex, and here some people will give the date of examination, and there'll be date of birth also will be given in one corner. In the other corner, you can see there is something called windowing. See this, and you can see the window on both sides. This is 2000 and here it is only 100. And look at the difference in the image. When you increase the window level and width, what happens is more and more dense structures will stand out. So when you want to see a bone, you have to change this, you will adjust the window. Thereby, that structures what we want will stand out. Suppose we want to see the air, we will make it minus, because minus 1000 and minus 100 was the range of Hounsfield, that density for air. So when we make the window minus, we'll see the air structure standing out. In the orbit, we need to see only the soft tissues, the soft tissues and the bone. So we will give the range around the soft tissue. Soft tissue will come between 50 to 100. So that range we will put to see the soft tissue. And when you want to see the bone, we'll make it into a much more higher range, like 2000 and 200. So we can see this window width, and there will be something, slice thickness also will be written here. See, 2 millimeters. Normally, we do 5 millimeters or 3 millimeters or 10 millimeter sections, because always we do a volume imaging and we can slice. If suppose we feel there is something missing, we can go back and reconstruct much more thinner slices, like 1 millimeter, 0.5 millimeter, and see if you have missed any tiny lesions. So that is the advantage of modern CT. This is windowing. Then next is laterality, means you have to look at the side. It will be marked as right. So, and always it is like this side will be right and this will be left. But in some cases, if the patient is taken in the prone position, this can change. So look at this marker right. So that will give you the side of the image. Then how do we take the image? Initially, we'll take something called a topogram. See this skull you see, and in this you will mark the area to be scanned. So this is the orbital area. If you want to see only orbit, we'll take only this area. But routinely, we try to cover the brain as well as the cellular, supracellular region, because the optic asthma, optic tracts are all there. No? So we'll try to cover all those areas. That is the ideal way of doing. We should include the brain also along with the orbit. And the PNS also, because many of the lesions from maxillary sinus can invade into the orbit. So we'll try to include the whole PNS and the brain, skull base, etc. while doing the scan. And once after acquiring this thing, when we are to acquire this images, we have to, if we want to get an axial image, the slicing should be like this. We have to plan on the image this along this, you are seeing one A line, no? And there's another line, you are seeing this R. This is from this is called orbitomeatal line. From the lower border of the orbit to external artery meatus. That is parallel to that, you will get the axial slices. So you will be taking axial slices by keeping cutting across this line. And this here you see there is a slight obliquity. This is around 30-degree angulation to this orbitomeatal line. Is in one way you will get the entire optic nerve in one go. You will get the whole of optic nerve till the chiasma. Otherwise, this optic nerve will be tortuous. It will be imaged in parts. So once you can acquire the images in many ways. You can take an axial, and if perpendicular to the axial, the C, if you are cutting across like this, you will get the coronal image. That will go parallel to the coronal suture. Here comes the coronal suture. So we'll be cutting parallel to that. And in order to take a sagittal, you will have to cut parallel to the sagittal suture. That is in the midline. Or take a coronal image and cut perpendicular to the coronal image. We get sagittal slices. So ideally, you have to see in all these three things, axial, coronal and sagittal, for a complete evaluation, because some relationship will be better seen in axial, some other thing will be better seen in the coronal. So you need to need to have all these three planes, and every image should be studied. So we already said the axial. So we'll go through some of the axial images. So this, then once you have found the side, right and left, you have to see which is the superior and which is the inferior aspect. So you know that inferiorly all the paranasal sinuses lie. So it starts from the level of the, when you look at the images, if you see big maxillary sinus, and this is a very prominent nose, so that is an inferior cut. Then as you go up in the central region, you can see the globe very nicely, and the lens is also seen. So this is somewhere along the center of the globe where you can see the optic nerve and the extraocular muscles. As you go up, you can see that this prominence of the nose, it flattens. And you will be seeing more of brain as you go up. There you can see the superior rectus and the superior ophthalmic vein crossing. So these things are very easy to read, and you have found that all the air thing will be dark. So the PNS, maxillary sinus, nasal cavity will be all looking, the lumen will be looking dark, and the bone will be white. And this vitreous or aqueous, these are all fluid-like, so they will all be looking dark because they are fluid. And the other structures will give a soft tissue signal, a gray signal. See the optic nerve, this rectus muscles, and you can see the wall, uveoscleral coat. You can't see this all three layers separate, like retina, choroid, and sclera all separate. It will be all seen as a single coat. And these structures will all have a similar, because they all have a similar density almost, so they will be giving a similar image, all be looking gray. So even when you look at the brain also, that is also has a similar texture, so that will also give a similar gray. Then as you go up, you can see this is an important landmark. The superior ophthalmic vein will be seen crossing from medial to lateral. And this is very important. You have to see the size of the superior ophthalmic vein. And these are the muscles. So in the when you take an axial view, see, this is the bone window. A bone window should be sharp like this. We have special algorithms. This computer will be having special algorithms for making images sharp, less sharp. And also you have to, if you want to study a bone, it should be sharp. And then only any small, tiny hairline fractures will stand out. And especially this medial wall. This is the medial wall. This is very thin and fractures are easily missed. So this is a lamina pepritia. And here this is a lateral bone. The lateral wall is formed mainly by the zygomatic and the greater wing of sphenoid. If you go through, you can actually identify each bones, because you need to have all the sections. And then this is the orbital apex. I'll come to that detail later. And this small, tiny, round things you see here is a nasolacrimal duct. And the coronal, we have found that coronal is a plane perpendicular to the axial. The axial we are cutting like this. If it is perpendicular to that, we get the coronal sections. Sometimes we'll have to, here they put a slanting line. It's because there may be dental fillings. It can give a lot of artifact and obscure the details. Because the dental fillings are very dense like metal. So they will obstruct much of the X-rays and produce freaky artifacts around. So we have to avoid that. That's why they put it slanting. Otherwise, we'll take it vertical only. So this section has to go beyond the sella turcica. When we take a coronal, it has to go from here to here so that the entire optic nerve, chiasma, and the tracts are seen. Okay. So in the coronal, most anterior sections, most anterior you will be seeing the eyelid and all, but the globe will be seen nicely in the anterior sections. You can see this is the globe, and on all four sides you see the rectus muscle. These rectus muscles and globes just stand out. You can see very nicely. Here you see the superior ophthalmic vein. I'll come to that in detail later. And inferiorly, you have the paranasal sinus. You can see the relationship of the maxillary sinus to the orbit and this orbital floor, this medial wall, and this roof of the orbit. All these things are very nicely seen in the coronal sections. And as you go behind, what happens? The structures near the orbital apex, you see that optic foramina, superior orbital fissure and inferior orbital fissure. Medially, there is a sphenoid sinus, and the inferior orbital fissure will be opening into this is the infratemporal space. So more anteriorly, you will get the globe. As you go behind, you see the globe ends and the optic nerve starts. The central thing is the optic nerve. All these structures have a similar signal. So actually, histopathologically, it is we can't see the histopathology of a lesion because the texture will be the same in CT. So MRI has an advantage over CT that we can make out many things extra with the MRI. Then in sagittal, in coronal and axial, we were able to see both the eyes in single slice. But in sagittal, we can see only one globe. It will usually, the slicing starts from the right to left side. So first image you see will be right. Otherwise, it will be marked in one corner, right or left, wherever they've started. So there, the roof and the floor is very nicely seen. This is the inferior rectus and superior rectus. These things are nice. This can be nicely seen in a sagittal section. In an axial section, the medial and lateral aspect will be better seen. Now, if you want to read a scan, you have to go through these following points. These are the checklists. Only if you look for each thing, you will see. Otherwise, you look at the image and just leave it like that. You may miss many things. You have to look for each thing. Look for the bony orbit. Look for the eyeball. Lacrimal gland. Lacrimal gland is seen on the lateral, upper lateral aspect. I'll show you if it is seen here. In the anterior sections, you can see here. This is the lacrimal gland. And then extraocular muscles, all the muscles. And importance of the orbit is that it is always symmetrical. So you can compare with the other side, the bulk, symmetry. What about the margins of the muscle? And the contrast, and muscle is the only one which enhances very nicely. So you can see if any enhancement is there or not. And extracorneal tissues, all the lids, conjunctiva, anterior structures, orbital septum, and intracorneal soft tissues like optic nerve, retrobulbar fat, superior ophthalmic vein, and finally the cella and paracellular region. So these many structures should be analyzed before giving a report. The bony orbit itself, you have to see all these things. One, you have to look for the dimension, any symmetry or asymmetry. Then each area you have to see roof, floor, medial and lateral wall, and orbital apex. Then look for the paranasal sinuses. Then at the orbital apex, you look for the superior orbital fissure, inferior orbital fissure, and the optic canal. And orbital, you only if there is a marked asymmetry, you need to report if the orbit may be small when there is an ophthalmia or when there is a nucleation, likewise, it depends. And this we see very rarely. And the roof, the roof is better seen in a coronal and sagittal view. You have seen that already. This is coronal view. The roof is better seen in the coronal and the sagittal, not in the axial. So that is why it is important that you have to see all views. So in the coronal view, and this roof is formed mainly by what all structures? One is the frontal bone and the lesser wing of sphenoid. So any fractures or any lesions arising from the bone, anything from the brain can also invade into the orbit. So all these things you have to analyze in this when you see the roof. Then floor and the roof are better seen in these two views. Medial and lateral wall are better seen in the axial scans. And in the floor, you have an important structure. There is inferior orbital nerve. So any fractures of the floor, this can get entrapped. This muscle also can get entrapped and can herniate into the maxillary sinus. So these fractures of the floor, roof, etc. can be well seen in a sagittal and coronal. Medial and lateral walls can be seen in the axial as well as coronal. Okay. So all the muscles you know now, this is superior, inferior, medial, lateral rectus. These structures stand out, and the optic nerve and the globe and the margins of the globe stand out. At a single look, you can see all this. But some structures you have to look for, like our superior oblique muscle. Superior oblique muscle, you know, it is on the medial aspect superiorly. So this is the medial aspect. This is the axial cut, upper axial cut. You see, this is the, you see, a thin structure here. See, there's a very thin structure. This is the trochlea and superior oblique muscle. Here you can see this small dot. This we'll have to look for to see. And this is a superior ophthalmic vein that is seen below the superior rectus. And as it goes medially, what happens? This goes laterally. The origin is from the medial aspect, it will be going laterally. This blends with the lateral rectus. Here and all, it will be difficult to see. All the levator palpebrae, superior rectus, oblique will all be seen together. In MRI, sometimes you will be able to differentiate because it has a better soft tissue resolution. And this ophthalmic vein will be seen below the rectus muscle. Inferior oblique, it's more anterior. You can see here, this is the inferior oblique. It also arises from the medial aspect of the floor, and it goes laterally, and it is inserted on the lateral aspect of the globe beneath the lateral rectus. So this superior and inferior oblique, you have to look for it, then only you will see. So here again you can see this D, this is a superior oblique. This is the inferior oblique, and this is a superior rectus, and here you can see the levator palpebrae separate. Okay. And nasolacrimal duct is another structure you have to see. In the coronal, you can see it very nicely. This is the thing. From the medial aspect, the lacrimal sac is not well seen. It will be going and opening into the middle meatus. Many a times it may be fluid filled, fluid filled. Sometimes you will see it as air filled. Any tumors from the nasal cavity can actually spread through this nasolacrimal duct into the lacrimal sac. So each time you have to look for these structures separately. Otherwise you may miss a tiny thing. Okay. Then paranasal sinuses, because they are always in relation to the orbit, you have to analyze the paranasal sinuses also. And you know that this maxillary sinus, it is better seen in a coronal or sagittal view because it lies below the orbit. These two are the sinuses, and a normal sinus will be air filled. If you see any fluid signal inside the sinus, that is abnormal. Then ethmoids is on the medial aspect. Both in the axial and coronal, you can see the ethmoid sinuses. And posteriorly, you have the sphenoid. So as the coronal sinus go behind, as the coronal cuts go behind, you get the sphenoid sinus. And the sphenoid sinus has a close relationship with the optic nerve. See, this is the optic nerve and this is the optic foramen through which it comes out. So this sphenoid sinus is lying on the medial aspect. Next, orbital apex. orbital apex includes those regions where the openings of optic canal and the superior orbital fissure are seen. It's far posterior. You can see here, this area is the orbital apex. They say it is, there is a posterior, it's very tiny, difficult to see. There are two tiny foramens on the medial aspect, anterior and posterior ethmoid foramens. And the area, some 5 millimeter behind the posterior ethmoid foramen is the orbital apex. And this includes, this is the optic canal and this is the superior orbital fissure. And in the coronal, you can see this is the optic canal, where the optic nerve goes. This is the sphenoid sinus. And this is a superior orbital fissure. In between, there is a thin strut, optic strut, which fractures. In fractures, it's very important to look for this strut because that fracture can impinge on the optic nerve. So this is the orbital apex. So each time when you read a CT, you have to look specifically for the orbital apex. Okay. Infraorbital foramen I've shown you before. That is also nicely seen in a coronal view. Here you can see that this is a section, coronal section, in which you can see all the foramina nicely together. So this is the optic nerve, and superior orbital fissure is very important because all the important structures come through this, and the superior ophthalmic vein also drains through this to the cavernous sinus. Inferior orbital fissure is the area where the foramen rotundum opens, and the foramen rotundum opens into inferior orbital opens into the infratemporal fossa. Infratemporal fossa, very rarely you can get tumors extending through this infratemporal fossa into the orbit. This nasopharyngeal angiofibroma is one which is very notorious to occupy in the retromaxillary region. That can sometimes get into the orbit through this pathway. So it is very important you have to look specifically for these fissures. Next is superior ophthalmic vein and the cavernous sinus. You know that superior ophthalmic vein, I already said, in the axial cuts, most superior cut you will see going from medial to lateral. In the coronal, you see this round thing. If the dimension is more than 3.5 millimeter, you have to take it as engorged and look for the cavernous sinus very nicely for any fistulas or any thrombosis or anything. So as you go posterior, you will have the cella with the pituitary gland, and either side is the cavernous sinus. These structures will look very dense, on contrast will enhance very nicely. So, and above is the optic chiasm. This chiasm and these things are very nicely seen on MR. If you are suspecting anything related to the optic nerve, you have to go for MRI. Because in this optic foramen region, this optic nerve, in this part is not very nicely seen. In MRI, this bone does not produce much signal. So this optic nerve is well seen. So every scan should go beyond the cella. It's very important. Next is the optic nerve. If you want to see in one stroke, you can take a slice like this. That is about 30 degrees from the axial plane. Then you'll get the entire optic nerve in one go. Here again, I told you this area is always not very nicely seen on CT scan, that optic canal region, the intracanalicular part. It's a very small part, still it is very important. So for that, MRI is, for optic nerve, I feel if you're suspecting something, you have to go for MRI. Okay. Then contrast is given when you are suspecting any vascular malformations. What we give is an iodinated contrast. It's an iodine-rich contrast. So in tumors, when you have to study the vascularity, the dynamic pattern of enhancement, infections for any abscess, suspecting any lesion from the pituitary gland or the cavernous sinus, the contrast is a must. And we can do it like an angiogram also. And here you can, each vessels you can see very nicely. Here you can see the 3D reconstruction. It's a volume rendering technique, we call it. You can see each vessels also very beautifully, and you can find out the lesion. This is, but the problem with IDIT, that heavy dose of this thing, this can impair the renal function. So it is very essential that the renal function should be assessed before every case that we take. If it is an elderly, especially after 40 years, if it is a diabetic, always check the serum creatinine and blood urea and do the contrast. We'll check the GFR in every case. If it is less than 35 ml per minute, it's better not to do the contrast. This is another technique which is possible with this volume imaging. We can actually make this live appearing images, like a 3D image. You see, here this is a fracture case with all the walls fractured, and here they put a mesh for the repair of the floor fracture. So these things can be well appreciated. For a facial-maxillary surgeon, these pictures are very important. They always look for this. And another important development in the field is 3D printing. This is something very new, in which actually they print out these, using these thin sections of the CT, they print out a 3D skull of human size. See, you can see this is not done by the CT scan. That sections have been analyzed and by another machine, and they have made this 3D this thing. This, for the facial-maxillary surgeons, this is very important because they can plan the surgery on these sections. This will be a life-size skull, and along with that they will image the fibula, scapula, or whatever bone they want to implant into that area. This was a case of actually CA maxilla which has eroded into the orbit. So they wanted to replace the maxilla. They removed the maxilla, so the floor of orbit was also gone. So they practiced by putting a fibula graft. So they will image the fibula also. So a similar fibula image will also be made, a 3D image. It's like something like a skull only when we look at it. This material is polylactic acid, PLA. It's a biodegradable material. So they can cut and place and the fibula, they can assess the length and practice and how it will look like. All these things even before the surgery. So the complicated facial-maxillary surgery, in Amrita, the surgeons practice on this and do it. And you know that CT is very fast means it's less than 1 or 2 minutes, the whole scan will be over. It is less time consuming. Only problem is it is an ionizing radiation. So we need to judiciously use this modality. Because we have been given, there is a maximum exposure permissible dose for every human being. So that is for the lens, it is 15 millisievert per year for the general population. And for a fetus, it is 1 millisievert. So these things are very important that we should not go beyond this dose. So we can see in a X-ray, when you look at a skull X-ray, the amount of dose they are getting is very minimal, 0.1. In CT head, it is coming to 2 millisievert is the radiation dose parameter. So here it is 2 millisievert. In chest X-ray, it's only 0.02. In skull, it is 0.1. So actually, this is within the permissible level. They said no, it is 15 millisieverts. But the thing is, if you go on doing this, if you want to do it unnecessarily, you can't do it because it might exceed the permissible dose. So only judiciously when it is needed, only we need to do. And another thing is in the pregnancy, we first trimester, we don't advise it, even though they say the dose to the fetus is less, but still we don't advise any scan in the first trimester, and it's better to avoid doing pregnancy because there is something called all or none phenomena. That is the radiation. Some reactions are radiation dose dependent. When the dose goes up, it can create problem, like it can burn the skin. But something are not dose dependent. Even with a smaller dose, you can get something. It can cause a mutation. We don't know. We don't have enough studies to prove all these things. So it's better to avoid during pregnancy as far as possible. Similarly, in the pregnancy, that contrast is also not given. If at all we have to scan, sometimes the patient comes with a fracture or a tumor, we are forced to do it. If we are giving this contrast, the iodine dose is very high in the contrast. So thyroid function of the neonate should be checked during the first week because it can suppress the fetal thyroid. And the breastfeeding period, if you are doing it, is okay. This can be given because only very little dose will be excreted in the breast milk, and what will be absorbed by the baby will be very negligible. So there is no harm in doing. If the people are very apprehensive, we'll ask them to withhold feeding for 1 day. Okay, the only thing which is very important is the renal function. Renal function is very important. Every case you have to check the creatinine and the urea, and if the GFR is less than 35, you should never advise contrast. Okay. So to conclude, CT is the primary diagnostic imaging modality for the orbit. Actually, no absolute contraindications. It is definitely indicated in trauma. For trauma, bony lesions and foreign bodies, CT is the modality. MRI is not used. And MRI is a secondary diagnostic tool when you're suspecting any vascular lesions, if in orbital infections, if it is involving the optic nerve, or if it is invading into the brain, meninges, dura, these things are better seen on MRI. The skull base is involved. We'll have to go, an additional MRI should be taken. But even then, CT cannot be avoided because the bony landmark is very essential for the surgeon. That will be seen only in CT. In such cases, we'll have to combine it with MRI. And in ocular things like means eyeball things, CT is of not much use. MRI is better, but ultrasound is the modality of choice. So only thing you have to remember is it is a radiation. So try to use it judiciously. Now go to the MRI.
Annie, would you like to say something?
Yeah.
I think that was a very nice presentation of CT. Dr. Sandhya?
Yeah. It was a recap for me also. It was a recap for me also. It was a very nice presentation. But for a surgeon, I think for an orbital surgeon, I always like to see the bone, so that we know where we are. More than the texture of the lesion, yeah, anyway, we have to take a biopsy now. Then, what did I want to say? Yeah. The in orbital floor fractures, the inferior orbital nerve is inside a tunnel actually. So yeah, that is usually not affected. Yeah, only when the inferior rim is affected, the inferior oblique can be affected, and the nerve to the pupil can be affected. Inferior orbital nerve is usually inside the tunnel, but it can be affected as it goes in the medial part of the inferior orbital. Okay, are you ready with the MRI?
Yeah, I think because all put as a separate folder.
Okay. Actually, Sandhya is my guru in art of living. Talk about that.
So all of you should do art of living meditation.
Okay.
To cleanse the mind and make it sharp. Okay. So yes. MRI works on a very different principle. CT it was X-ray, but MRI it is on magnetic field. This is just the basics because I can't go into the details because it's very intricate. Thing is, you know the structure of an atom. No? There is a central nucleus which contains neutrons and protons and outer electrons. In central nucleus, these neutrons and protons are usually of equal number. and the protons are positively charged and the electrons are negatively charged, and they are also of equal number. So the atom is usually electrically neutral. Sometimes it happens that there will be an excess of proton, like in hydrogen proton in water. When it dissociates H plus and OH minus, that H plus is only one single proton in it. Normally the protons will spin in one direction and the neutron will spin in opposite direction, and the spin cancels out. So if there is an excess of proton, only one proton, what happens? There will be an extra spin there. So only such nuclei means that is a spinning charge. A moving charge means it is an electricity. A moving charge is electricity. So whenever there is a moving electricity, it is said that there will be associated magnetic field will be there. So when there is an electric field, there will be a magnetic field. When there is a moving magnetic field, there will be an electric field will be induced. So that is the basis for MRI. So our body is full of water, and there are a lot of hydrogen protons which are spinning, and it is a moving charge. So this moving charge means there will be associated magnetic field. That means every proton is a tiny magnet. So our body has a lot of tiny magnets. So what we are doing this here is normally these tiny magnets are all randomly arranged in the body. When we keep it in an external very strong magnetic field, what happens is all this will get aligned in one direction. You can see some very energetic magnets can go in the opposite direction, but most of it will align in the direction of the external magnetic field. And what we do is then we are applying another small magnetic field so that those are aligned parallel, will start picking up energy from the extra field applied, and they will go to the opposite direction. They will go to the opposite plane. You can see that here. All those in this direction some of this has started going to the anti-parallel high energy state. Then what we are doing is the extra energy, extra magnetic field applied, when we remove, what happens? All this will go back to the original state. How they go back depends on the hydrogen proton in varying tissues. Means hydrogen proton in water will go back very slowly, while that in fat will move very fast. So all the tissues, the movement of the hydrogen proton back is varying. It is a time difference which gives rise to signal in MRI. In CT, it was the absorption of X-rays by the tissues. That was different because some were dense and some were less dense. But here it is the timing of the hydrogen proton, timing of the hydrogen proton to go back. That is different. So based on which that all the tissues will give different timings and different signal. So in order to bring out the signal, we use various weighted images. This is T1 weighted image, T2 weighted image, and proton density. These are the base images we take. In T1 weighted images are mainly to see the anatomy, and T2 weighted is to see the pathology. So I'll show you a few images. There are also the slicing sections. Everything is like CT, you take axial sections, sagittal sections, coronal sections, and you have to read all these sections to get a complete information. So T1 weighted image means that if one main difference from MR and CT is in CT, the bone will be always white. In MR, it will be dark. Because there are no mobile protons in the cortical bone, it will never give any signal. So the bone will be dark. In whatever MR image, it will be dark. So it is very easily. So first thing, some of the CT image, MR images will resemble CT very much. You will not know whether it is CT or MR. If you are in confusion, you look at the bony calvaria. If it is dark, it is MRI. If it is white, it is CT. Okay. So this is a dark signal. And in between, you are seeing some gray areas here and there sometimes. That may be the marrow. Marrow can give varying signal depending on the fat content, but the bone, cortical bone will be dark. And the fluid will be dark. So you can look at the CSF fluid, ventricles and the sulci and the vitreous chamber, you see it will be dark. So that is a T1 weighted image. And you see when you look at the fat, it will be always bright, whatever it is. In T1, fluids will be dark and the fat will be bright. This you have to remember. In T2 weighted image, all the fluids will be white. Fat will be always white. Here also the fat is bright, but the fluids are bright. You look at the CSF and the vitreous chamber and the bones are dark. So a T2 weighted image means the fluid will be bright. There are other parameters for you to easily identify. You just look at the image like this. So when this is a T1 weighted image, you can see all the other structures will have a gray signal. See the optic nerve, extraocular muscles, and here also you can't differentiate that three codes separate. Uveoscleral, retina, all the codes will be looking the same. And the vitreous will be dark, retroorbital fat will be bright. So this is a T1 this thing. And in between here in the zygoma, you see a bright area. The cortex is dark. The cortical bone will be always dark, but the marrow can give different signals. As the aging starts, the red marrow will be replaced by fatty marrow, so it will become more bright. Fat will be bright in both T1 and T2. But in the younger age, this fat will be dark because of the red marrow. But you just look at the cortical bone and the orbital fat, and you can make out all the other structures because of the fat will be very nicely seen. And after contrast, when you give contrast, what happens? Everything will be like that only. You see, bone will be dark, fluid will be dark, but the only thing which enhances is the extraocular muscles. Extraocular muscle will show enhancement. If it is not enhancing, it is abnormal. Here you can see the optic nerve can be traced through till the chiasm like this. This image is not a very good one. Otherwise, you can see this very nicely. And sinuses air will be always dark only. Whatever be the sequence, the air and bone will be dark. So this is a T1 post contrast fat, and we call it fat suppressed. Why? Because the fat, whatever sequence will be bright, we will be doing special sequences to suppress the fat signal. Then only any tumor in that area will stand out. So in post contrast, we tend to do sequences to suppress the fat also along with that. You see all this fat here, which was bright, is dark. Retrobulbar fat is black. So the whole thing is black. Only thing which is enhancing is the extraocular muscles. And this is a coronal image. Sections are the same as in CT. You can see this is more anterior image. That's why you're seeing the globe very nicely. And here you see fluid is all dark. So it is a T1 weighted image. Air is dark and the fat is all bright. And these are the muscles, medial, inferior, superior, lateral rectus muscle. And these muscles are all showing a gray signal. And it is not enhancing, there is no enhancement. So it is a plain T1 coronal weighted image. Now you look at this. This is again another coronal image. It's far more posterior. Globe is not there. That optic nerve seen. All the muscles are seen. This is the superior oblique is seen here. And here the thing is globe is not there. Then you look at the CSF. See the CSF is bright. So this is a T2 weighted. Looking at the fat, you can't say because in both T1 and T2, the fat will be bright. So you look at the CSF, that is bright. So this is a T2 weighted image. And this is another sequence. In MRI, you can't get away with one sequence. You have to manipulate a lot of sequences to bring out the pathology. So it's slightly more complicated than CT. Here, it is actually something connected to optic nerve here. Optic nerve, there will be a sheet of CSF around. And because the CSF, this is a T2 weighted image. You look at the, this thing, fluid is all bright. So it is a T2 weighted image, but they suppress the fat, you see. So in T1 also you can suppress the fat, in T2 also you can suppress the fat. It's called a stir image. So when they suppress the fat, that CSF space stands out. Otherwise, fat is also white, the fluid is also white. You can't see this so nicely. So inside this, you will see the optic nerve very nicely. So if any swelling, any alteration in the optic nerve signal, like in optic neuritis, we have to do this sequence is a must, where you suppress the fat so that the fluid will stand out. Inside, you can see the optic nerve nicely. So MRI is not that easy as CT because lot of manipulation with the sequences is needed. This is a sagittal image. Again, this will look like a CT, but when you look at the cortical bone, it is dark. So this is a MR image. And you see the globe is dark, CSF is dark. So it is a T1 weighted image. And the fat is white. So it is not, fat is all white here. So there is no fat suppression. It is a plain T1 SAG image. You can see inferior rectus, superior rectus, optic nerve, fat, everything. This is another T2 SAG image. You can see CSF white, globe is white. Okay. T1 shows anatomy very well. T2, when there is pathology, that will be very nicely shown. So this is as in the CT. You know, you have to look for the side, right, left, anterior, posterior, superior, inferior. Identify the cuts. And the coronal scans also, you know, it's the same thing only here. And in contrast studies, many times, most of the cases, we have to give contrast. So in T1, contrast is different from in CT contrast. This is a different gadolinium-based contrast. What they do is they change that relaxation time. We said, no, this is all depend on the relaxation time of the hydrogen proton. So they can reduce the relaxation time of the proton and bring out this brightness in the lesion. So this, and along with that, the fat suppression, because the fat is also very bright, so it will be difficult to differentiate a tumor from the fat. So in all cases where you give contrast, we'll do fat suppression. Okay. No, so when you just see these images, you look at the central image. Here you see this is all dark. No, CSF is dark and the bone is dark. So it is a T1 weighted MR image. Fat is bright. And these are the extraocular muscles. When you look here, see fat has been suppressed everywhere. So it is a fat suppressed image. We said it is a T1 weighted because this is dark. Fluid is dark. And here the muscles are enhancing. So they have given contrast. So it is a contrast T1 fat suppressed. Similarly, you look here, the fluids are bright. So we understood it is a T2 weighted image. But here again, the fat is suppressed. Some cases we have to suppress fat and see. So this is a T2. To look for the optic, fluid along the optic nerve and optic nerve, we have to suppress the fat in T2. So this is a T2 plain fat suppressed image. See, this series of anatomy is the same as CT. Only you need to recognize the sequence. This is a T1 again. See, it's all dark. CSF dark. This is dark. And fat is bright. So this is a T1, not fat suppressed and no contrast. And when you look here, you see the muscles are enhancing. You see even the mucosa here will enhance. If there are any mucosal inflammation, that will also enhance. But there is no fat suppression here. Fat is bright. So you can understand if there is a lesion here which enhances, only when the fat is suppressed, you can see it better. So in all T1 contrast, we usually give a fat suppression. Here you can see that in this image. Down, this is a contrast is given with fat suppression. So you can see this very nicely. See, this is optic nerve. The margins are very shaggy here. There can be some infection or inflammation along the optic nerve. So this will be nicely seen when you suppress the fat. And this is a T2 with fat suppression. You see all the fat is suppressed. Then cella and paracellular region. These regions are better seen in MR contrast. See, this is the coronal section, which is far posterior. This is a sphenoid sinus. You can see the pituitary gland. On either side is a cavernous sinus. A normal cavernous sinus will be concave or straight. If it is convex, means there is some pathology. It's one thing you have to know. Inside, you see this dark area. That is a carotid artery. It is important when you have to look for carotid or cavernous fistula and all those things. You have to see for all the structures. And there are nerves along the, with very high resolution only we can make out. In routine scans, we don't see all these nerves along the walls of cavernous sinus separate. We can look at the cavernous sinus, ICA and pituitary gland, and there will be optic asthma above here. This is the optic asthma. And you can see the bifurcation here. It's not well seen in this. So these structures you have to see after you study the orbit in MRI. So this is just to show you one case. This is the cavernous sinus is bulky here as compared to this side. See, this is bulky. The margin is convex, means there is some pathology here. Okay. So this is a T1 weighted image. This is a T2 weighted image. And this is post contrast actually, but they are not done fat suppression. So we cannot see the lesions very nicely unless you do a fat suppression. And we can do angiograms. In CT also we have seen. So similar angiograms may be needed when you have to define a arteriovenous malformation or a fistula. Or sometimes you want to study the dynamic nature of tumors. Because some tumors will enhance in the early phase and later phase it washes off. So when you want to study that, we'll have to do angiography, dynamic sequence. And the contrast we use is gadolinium. This I already covered. The contrast is gadolinium, and postnatally it is not given in pregnancy because they say that it secretes into the amniotic fluid and it acts as an irritant to the baby's skin. Postnatally, lactating mothers you can give, there is no harm because very negligible amount is being absorbed in the lactating, in the breast milk. Antenatally, we don't advise gadolinium. Lacrimal gland is one structure which I forgot to show. You know, it will be seen in the upper outer quadrant. It's already said the cortical bone will not produce any signal. It will be dark. And if marrow is there, that will be seen high signal in old age due to fatty conversion. And the advantage over CT. CT is the prime modality because it gives you all the basic things needed. This MRI has a better soft tissue detailing. And you can use various sequences to bring out the texture of the lesion. But the thing is, only when it is really needed when you have to evaluate the optic nerve. Because optic nerve won't be very nicely seen on CT. Subtle demyelination and all those things will be better seen on MRI. And if any lesion is there which is infiltrating into the dura, meninges, all those, that intracranial extension MRI will be of help. But still it should be combined with CT because to see the bony landmark. And bone marrow lesion, there are certain situations when the cortical bone will be intact, only the marrow will be involved. Like myelomas. In such cases, marrow lesions can be seen only in MRI. If you are suspecting such plasmacytoma, multiple myeloma and all, you will have to do MRI. But MRI has another, CT when you see absolutely it has no contraindication except that it is ionizing radiation, but still the dose is very negligible. If we use it judiciously, it won't be of much harm. But MRI has certain absolute contraindications like if there is a metallic foreign body, better in trauma foreign bodies go for CT only. Because if it is a metallic one, it will get magnetized when you put the patient in a magnetic field and it will start moving and injure the structures. Then cardiac pacemakers, aneurysm clip, cochlear implant, these are all absolute contraindications. You should know. So it is always essential you should ask for all these things before advising this MRI. Then during pregnancy also the safety is not known. So we don't use it in the first trimester, both CT and MRI. They say even the eye makeup should be removed because some of it contains the ferrous elements. And all the ornaments should be removed before taking. And sometimes this is a slightly more prolonged examination. You have seen you have to do many sequences to bring out the texture. So it takes long time. CT will be over in a split of a second. It takes minimum of half an hour for an MRI to be done. And it is more expensive and claustrophobic thing. This is a very closed space thing. The machine will look like CT only, but the space is more narrow. So some people panic once they put inside this thing. And it is not suitable for this fractures and bone. These are the disadvantages of MRI. So in short, CT should be the primary modality of choice. It's a better option if you're suspecting a lesion in the orbital apex, optic canal, intracranial extension. And for vascular malformations also, it is of additional help. Okay, this is already I've said all this. Anything to say?
Thank you, Sandhya. Excellent presentation. Dr. Ani, anything to comment on?
The aneurysm clipping and all are done by the intervention radiologist or by you all only?
No, interventional radiologist, that's a separate.
Okay. So for noting the small indirect caroticocavernous fistula, meningeal arteries connecting to the cavernous sinus. Indirect, we will have
DSA will be better. In that you have to do a direct angiography.
DSA full form. DSA is full form.
Digital subtraction angiography.
Subtraction angiography. Okay.
We have CT angiography, MR angiography, but digital subtraction is directly we are injecting the contrast into the arteries and doing. So that is a far higher resolution than this MRI and CT. Small, tiny vessels cannot be seen. MRI is very poor, CT is slightly better. But for such things, we have to directly find out and occlude that vessel.
Okay. So even small vessels can be seen in the digital subtraction angiography.
Digital, it is excellent resolution, some 1,000 times better than this.
Than ordinary angiography. Okay.
Yeah, ordinary angiography. That maybe what you are meaning ordinary angiography is DSA.
Yeah. The patient may present with simply glaucoma and some mild congestion, mild proptosis. There may not be any pulsation. So, so how do you diagnose indirect caroticocavernous fistula? That means the small meningeal arteries connecting to the cavernous sinus. So digital subtraction angiography.
DSA is needed. We'll have to evaluate with CT or MRI first. Then if you don't see anything gross, we'll have to go for DSA.
To go for digital subtraction.
Yeah. It is a must.
Okay.
We'll go to ultrasound now.
Dr. Sandhya, 1 minute. I think it has settled the problem, which is best, CT or MRI. That is the usual confusion. And
I told CT is the primary modality.
Yeah, that is what. That is a very big message to our PGs because they usually select the MRI first. So
yeah,
I'd just like to, Ani, 1 minute. I'd just like to invite Dr. Babu Kishomar here. Sir, come on.
One more
Babu, sir.
Hello. Hello.
So please come on then. Yeah.
That is an excellent presentation, Dr. Sandhya.
Hello.
You presented comprehensively.
Dr. Sandhya is a KSOS president.
There's one more on ultrasound. A small presentation on ultrasound.
Sure.
Many things are new for us.
Okay.
For MRI and
I have one
concept is clear.
I have one question.
Yeah.
Is there any condition? What is our problem? Is financial problem of the patient. So sometimes, is there any condition where you directly want to do MRI, suggest MRI rather than CT?
Except in trauma, if you want, you can go like that. I feel trauma, foreign bodies, only CT will be. Otherwise, if surgeons want to operate, they want to see the base skull and all those things, then they ask for CT.
If there is
other conditions, you can directly go for MR. Amrita will do MR only.
That's
if you want to see the optic nerve,
everywhere it is said CT is the primary modality.
Yeah.
If you want to see the optic nerve and if you're suspecting intracranial extension, orbital apical lesions, for all this you can do MRI. For these surgeries, not much done also. So you can do MRI. But for if you're referring any patient with MRI, I will take a CT again. That's all.
Understood. Point taken.
Yeah.
Thank you.
Can I ask a doubt?
Yeah.
How you do suppression?
How you do
fat
suppression?
suppression.
It's all
Fat
done by the
suppression.
machine. There are many ways of suppressing fat. It's all physics only that we need not understand.
Okay.
Very intricate physics. If you press the button of fat suppression, the machine will suppress the fat.
That would be very good if it is done physically for us also, no? Okay.
Okay, very nice presentation.
Okay.
Actually, now
Image.
it's becoming very, after your class, we are feeling it's very easy, MRI and CT. Thank you so much.
Yeah. Okay.
Now I'll go to ultrasound. You can see, no? You can see the slide, no?
Yes, we can see.
So this ultrasound is a very different principle from CT and MRI. Here we are using sound waves. So normal audible range is from 20 to 20,000 hertz. It's beyond that is the ultrasonic waves. Beyond the audible 20,000 hertz is the audible range. So the strength we use for scanning is in 10 to 18 megahertz. It's megahertz that is used. So the principle is that like an X-ray, the sound waves will pass through the body. So some tissues will absorb it, some tissues will allow to pass it, some will reflect it back. So these fluids allow the sound waves to pass very easily. So the fluid structures are very nicely seen. So that is one advantage for eye. Only the globe can be studied using the ultrasound. The globe is better studied with the ultrasound than CT. And another advantage is it is very superficially located and we can use very high frequency transducers. So the resolution is also very good. The problem is this will not, the bony structures will not allow the ultrasound to pass through, to reflect the entire thing back. So we cannot study bones. And another thing is air. This air also will reflect the entire sound waves back. So we cannot study structures which are covered by bone or air. So lungs, it is not useful, and bony brain and all is covered by bony calvaria. Bony orbit we can't study. For the globe, this is very ideal. The thing is, when we are using a high frequency transducer, only the structures which are close to the transducer will be seen. Deeper structures also cannot be studied. So in that way, globe is a very ideal setup for studying with ultrasound. And this is very cost effective, means no adverse effect and very cheap and it's well tolerated. You can do it everywhere and these machines are very easily available. Another advantage is real-time imaging because we can actually see the vessels pulsating, movement, everything we can see. It's something you see real in front of you. So the thing is, the most anterior structures like cornea, conjunctiva, anterior chamber, iris. With conventional sonography, these structures are not well visualized, but there are now newer machines with very high frequency, like 50 to 100 megahertz, which gives a microscopic detail of the cornea. So I'll show the images later. So this is a normal image. You can see these structures, the cornea, these area will be hazy. Only the deeper structures are nicely seen. Here also the problem is all the three codes are seen together. You can't separate the three codes of the eye. And the optic nerve is very faintly seen here. Extraocular muscles will be seen side. But this is better to study the globe. The lens, normal lens is not seen unless it becomes cataractus. So here only the margins are seen. This is the sclera. So all fluids will appear very dark and other structures will come in a gray shade. Sorry. Here you can see, we can do a Doppler evaluation also to study the vessels. You see the central retinal artery here. I'll come to that later. And this is how we do the scan. What we do is we ask the patient to close, put a gel and put the transducer. There are small hockey stick transducers which can be put on the globe. But some people prefer to do it this way. They paralyze this conjunctiva and put the globe directly. But we don't prefer to do that because it can cause abrasions. And some put a standoff pad like this, a water pad, and put the transducer above that. So what happens is the cornea, the most anterior structures will be slightly better seen. And I'll just show you a few images. Normally, this globe will be crystal clear like this. If you see fine echoes, means there are bleed. It's a case of vitreous bleed, choroid detachment. You see, like there is a calcium will be appearing dense because it will not allow the sound to pass. All the structures behind will not be, cannot be evaluated. Produce a shadow here. It's a calcification in the optic disc. This is a retinal detachment, the classic V-shaped, small choroidal mass. Like it's a persistent hyperplastic hyaloid artery. Likewise, very simple to do. And color Doppler is advised when you want to evaluate the central retinal artery or posterior ciliary vessels. The thing with this thing is, this importance is this artery and the vein has got a different pattern. When you do a pulse, something called pulse Doppler, in which we will study the nature of the waveform. So artery has got a form like this. There is a peak systolic wave, then there is a diastolic form. Means the systole there will be a sharp flow, diastole it comes down. This is a classic pattern we see in arteries, in central retinal artery. In a vein, there won't be this fluctuation with diastole and systole. It will be a continuous flow. You can see here, you see here, it's a reverse flow, it will be seen like this. So in carotico cavernous fistula and all, what happens, actually that fistula, the ACA is rupturing into the cavernous sinus. And this arterial thing is being thrust into the superior ophthalmic vein. That ophthalmic vein, instead of showing this continuous pattern, it starts showing this fluctuating pattern like an artery. This is one way of diagnosis, but we usually use MRI or angiogram for diagnosing that. Then another thing they say in diabetes and all, that flow after some atheromatous changes or something happens, the flow to these arteries become less. So we measure a resistive index from the systolic and peak systolic and diastolic flow. The resistive index increases when the arterial inflow lessens. So if we can diagnose this increasing resistive index at an early phase, you can start treating earlier to prevent the progression of the disease. Not much of use. This is what I've been telling. There is a 50 megahertz. I don't know whether it is available in India. A 50 megahertz probe. Usually what we use is up to 18 megahertz. Here it is 50. Such high frequency probe, you can see the microscopic detail of the cornea. See the epithelium, endothelium, corneal stroma, anterior chamber, iris, ciliary body, this angle. In glaucoma, they see this obliteration of this angle. All this can be measured using this. This is very high, like a microscopic thing you will see. You can measure the depth of the anterior chamber, thickness of the lines, thickness of the ciliary body, iris. So when there is a foreign body, all these things are not very nicely seen over conventional ultrasound. And here there is a hematoma inside the cornea. And see this addition of iris into the cornea. The shaggy interface is seen. See, it's very shaggy when there is infection. You get such. Otherwise, these margins are very sharp. So these things can be studied using that. But I feel it is clinically also with your instruments you can see that. So advantage of ultrasound is low cost and there is no ionizing radiation and there is no contrast also. It's portable. You can take it anywhere. You can take it near the patient and do it. Examination time is also slow. Assess the vessel. But the thing is only globe can be assessed. We cannot see the orbit or the thing as a whole. If we are seeing any lesion inside the globe, it is going into the retroorbital fat and all, you cannot see very nicely. You have to evaluate with CT or MRI. That is imaging part is over.
Thank you, Dr. Sandhya. An excellent, very nice presentation. Ultrasound biomicroscopy is available in many hospitals in Kerala. It's in. It is,
but not the high resolution one. That high resolution
but
is
it's
not there.
There is a one in Regional Institute in Trivandrum.
Yes.
But I don't know how much it is. Yeah, but I don't know how much it is being used, but it is there. Is it there with you, Dr. Ani? There, LF?
No. We don't have the high resolution one.
I don't know.
Then, we use it in oculoplasty. We use it mainly for surface tumors.
I thought people may not be buying. It must be very costly. So only you can study the cornea, nothing beyond that.
No, we can study the surface tumors of the conjunctiva also. And the angle. The angle, iris cyst, iris tumors, anterior part you can do. But then very few patients require that, and who will pay? Who will pay for all this? Okay. Now we are going on to the case presentation.
Yes.
Yeah.
Dr. Lakshmi, please unmute and present the first case.
Should we wait till the whole case presentation is over, or can we interrupt in between?
Proptosis, then I will show how it is being evaluated. Then.
Oh yeah, after the case presentation. So after the case presentation, I will say a few comments on the case presentation, and then you can see how it is.
Good morning, dignitaries on the virtual platform. I hope you can visualize my slides here. I'm Dr. Lakshmi, Government Medical College, Thrissur, postgraduate student, second year. I'm here to present a case about a patient who came to our OPD. He's a 70-year-old man with type 2 diabetes and systemic hypertension, attended our OPD as a referred case. His chief complaints were swelling on lateral aspect of the left eye, which was for a duration of 5 months. OPD. He's a 70-year-old man with type 2 diabetes and systemic hypertension. It was a slow-growing swelling, which was gradually progressive. There was no associated pain, defective vision, or history of any trauma or discoloration. He consulted a local hospital and was advised a CT orbit from there. Now coming to the relevant past history of this patient. He had a cataract surgery in the left eye a few years before, and there was history of abdominal lymphoma, which was detected in 2008 and was treated for the same. He underwent a surgery, and later on there was chemotherapy. The records were not available with the patient for about the treatment. In ocular examination, the head posture was normal. Extraocular movements were normal. The vision in the right eye was 6/24. With pinhole, it was improving to 6/12. The color vision was normal, and the orbital rim was intact. The eyelids and eyelashes were normal. The conjunctiva cornea was normal in structure. Anterior chamber was normal in depth, and no signs of uveitis were present. Iris was having a normal pattern and color. The pupil was round, 3 millimeters. Direct and concentric reflexes were brisk. In lens, there was immature senile cataractus changes. Anterior vitreous space showed no cells, and the fundus picture showed the media clear. Disc and vessels were seen normal. Cup disc ratio was 0.3, and neuroretinal rim was pink. and foveal reflex was present. In the left eye, the vision was 6/18. With pinhole, it was improving to 6/12. The color vision was normal. Orbital rim was intact. In the examination of the eyelids and eyelashes, a swelling of 10/10 millimeters were noted in the infralateral aspect of the orbit. The swelling was round, firm, and rubbery in consistency. The conjunctiva and cornea appeared normal. Anterior chamber was of normal depth and no signs of uveitis were present. Iris had normal pattern and color. Pupil was round, 3 millimeter in size. Direct and conjunctional reflex were brisk. The lens was pseudophakic. Anterior vitreous face showed no cells, and in the fundus examination, the media was clear. Disc and vessels were seen, normal. Cup disc ratio was 0.3. Neuroretinal rim was pink, and foveal reflex was present. No other changes were detected. And this is the clinical presentation of the patient. As I have described, you can see a round swelling, which approximately measured 1 centimeter in size. It was round, seen in the infralateral portion of the orbit. It was firm in consistency, and no periocular changes were present, and the extraocular movements were normal. My provisional diagnosis for this case is orbital lymphoma, and I present metastasis, sarcoidosis, and inflammatory pseudotumor as a differential diagnosis for the above case. Are the CT images of the above mentioned case. You can see a mass in the orbit, the left orbit, which is pushing down the optic nerve inferiorly.
Is the case over?
Yes, ma'am.
Okay. So when you're presenting a proptosis case, did you say how much there is a proptosis? Is the orbital mass, any orbital mass? You should say, you should measure the proptosis. If you don't have an did you do that? I missed it out.
No, ma'am, there was no proptosis in the examination.
You have to measure anyway if there's an orbital mass. Then you go on to describe the exophthalmometry. Okay, then ocular movements, then describe the mass. Okay, then you have to do the examination, the sensation at the area of the mass. Is it affecting the extraocular muscles by the movements? Then you have to do the sensation in the area of the mass. It's an inferior orbital mass. You have to do the inferior orbital sensation, superior orbital sensation. Then another thing, don't give so much importance to the anterior segment. That when you are doing a proptosis presentation, you have to do see if there is sinus tenderness, regional lymph nodes, preauricular and submandibular nodes, and look for pulsation.
Okay.
All this should not be missed out in an orbital mass presentation. And when you're saying the provisional diagnosis, points for and against. Points for, why did you say it's a lymphoma?
Because he
And
had
why
a
did you
history
say
of
it's a sarcoidosis? Yeah, okay. Write that down, and you have to say that also. Okay.
Okay.
Yeah. Now we'll go on to the CT. What did you see in the CT? You should not look at the report initially. You write down your own report and then only look at the report. That is what should be ideally be done. In a busy OPD, you may not have, but look at the report the last if you have missed out anything. Don't look at the report alone. Okay, it may be wrong most of the time. So CT scan, just tell us what did you see? You can put the picture of the CT scan. Okay, you can't. What did you see? Tell us what you saw on the CT scan.
I saw a hyperdense mass which was present in the intraconal part. Hyperdense was not given because
contrast given. Did you see if there's contrast given?
No, contrast was not given because he was having a deranged RFT levels. So
Okay,
Contrast
how do
was
you know
not
in a
given.
CT if contrast is given? There will be a small, I don't know if Sandhya, in all CT scans it is there like that. So there will be a small plus C.
Yeah, sometimes they will give that plus C,
Plus
or you
C.
look at the vessels here.
Yeah, vessels,
You can
are the vessels.
basilar artery or anything, or the muscles will enhance. Muscles
Okay,
will enhance.
even in the CT.
Right, CT also.
Okay.
But
So,
you look at the vessels, that is more important. Basilar artery or this vessels will be going on.
Vessels will be more prominent. I don't know if CT report contrast is given. Okay, tell me, they describe the
not
mass.
given because the vessels are not seen. It's not,
Not seen, yeah. So tell me the report, just tell how you. Lakshmi,
And
tell me
it is
the.
slightly hyperdense mass, which is ill-defined. Hello.
Ill-defined.
It is slightly mildly hyperdense mass, which is ill-defined and is present as a mass lesion in the intraconal part of the orbit, which is slightly displacing the optic nerve inferiorly and is also seen to be infiltrating adjacent muscles.
Yeah.
You can't say it is infiltrating. You can say it is the muscles are not seen separately. Okay, that is how you can say. Muscles are not, it's seen in the superior orbit. How do you know the globe is pushed down, the optic nerve is pushed down from the sagittal image, no?
Yes, ma'am. The image is shown here.
Enlarge it. I was going to tell you that. Sandhya, is that optic nerve being pushed down? Medium?
Yeah. Here you can
pushed
see
down. Okay.
Pushed down superiorly.
It is a well-defined, but well-defined mass, irregular, isn't it? Well-defined. It's
shaggy margins.
Yeah, well-defined but irregular mass. That's how we can say.
It's a soft tissue mass.
Yeah, soft tissue mass. It's growing. Is it along the muscle, superior rectus muscle? Is it growing along the muscle?
Yeah, it has the shape of the superior rectus
muscle. Yeah, that is what I think, isn't it? It's
But,
molding along the superior rectus. Okay. So the duration is 6 months, and 8 years back he had a lymphoma. He had treated for systemic lymphoma. So 6 months duration lymphoma, you should think about immunosuppression. Did you do? You should always do a HIV and what is that? HBsAg immunosuppression. He had his renal function was deranged. Okay.
Yes, ma'am. He was a diabetic, so maybe related to that.
Yeah, lymphoma growing very fast. You have to think about immunosuppression. HIV should always be done. HIV and HBsAg. Then what else is there? So is the what do you plan to do? What is the further management?
He was advised.
See that is the coronal image and the axial image. You can see it's growing around the globe. Lymphoma typically grows around the globe into the subconjunctival space and along the muscles. That is a typical picture of a lymphoma. Okay. So a biopsy, yeah, that is the all the images which are seen. And you can't see the muscle separately.
No, ma'am.
Yeah. Is there any bone erosion? You have to mention all that. Is there any bone erosion? Pressure effect you already said. Bone erosion should also be mentioned. Bone is absolutely normal, right? Okay.
Bone is absolutely. This is the CT finding. It says that there's a hyperdense left orbital mass lesion.
You just read out from the CT. Hyperdense is when you give contrast, isn't it, Sandhya? Okay, I don't know.
You can give it as a soft tissue mass.
Soft tissue mass, yeah.
Prolateral.
Okay. So, because of the lymphoma diagnosis earlier and the CT finding, you can say it's a lymphoma of the orbit, which is the other orbit is normal. No, you should always look at the other orbit also to see if there are any lacrimal gland enlargement. Lacrimal gland can also be enlarged in a lymphoma.
In this case, also
ocular muscles.
lacrimal gland is involved.
In this
It's bulky.
eye. Okay.
And this side
Extraocular
also.
muscles can be enlarged. Okay, this is pushing the optic nerve medially also. Yeah. The coronal section, you can look at the optic nerve positions in both eyes and see if it is pushed down or pushed medially or laterally. Okay, now Sandhya, you can.
I'll give a short presentation how to evaluate the proptosis.
Okay.
Show few cases. Proptosis. So in the assessment of proptosis, in imaging, this is how you do the thing. We draw a straight line between the zygoma. This is zygomatic arch. Here you can see this is a CT image because the bone is white, and this is an MR image. This is a T1 image. See, again the globe is dark. So from here to here, zygoma, interzygomatic line. Then from here to the anterior margin of the globe. And this distance should be normally 21 millimeter or less. Any asymmetry greater than 2 millimeter or a value above 21 millimeter means there is proptosis. Normally, this will cut across the globe, either through the equator or slightly behind the normal case. Because here this is bulky, globe has been pushed anteriorly, it is going out into the retrobulbar space. So just looking at this, we can know that this is proptosed. Then you have to go through the checklist, which area is affected and what is causing the proptosis, whether it is arising from the bony orbit, eyeball, lacrimal gland, extraocular muscles, all the extracorneal tissues, intracorneal tissues, optic nerve, retrobulbar fat, ophthalmic vein, cella, paracella. This checklist you have to go. And routinely, these things causes proptosis. One is the orbital tumors. Orbital tumors can arise from the lacrimal gland, or it can be a primary ocular tumor or a secondary orbital tumor invading from the surrounding structures like PNS, nasal cavity, or it can be a metastasis like in lymphoma or from elsewhere, or it can be a vascular neoplasm like hemangiopericytoma. These are the for orbital tumors. And vascular abnormalities like venous varus, AV fistulas like caroticocavernous fistula, they can also cause. Then orbital infections, inflammations, pseudotumors, all those things. And metabolic causes, Graves' disease. These four headings you have to see. So when you see a neoplasm, you have to see the size, location, size, and what about the margins, whether it is well delineated or diffuse. Here it was more diffuse. It was a well delineated lesion, but it was diffuse. And what is the shape, whether it is conforming to the shape of the adjacent structures. Here it was going round the globe. And margins, whether it is smooth. If it is smoothly marginated, it will be a benign lesion, or it is an irregular margin like in a malignant lesion. What is the effect on the surrounding structures? Whether it is displacing. Here it was displacing the optic nerve down, and it is infiltrating. When there is infiltration, you won't see the adjacent structure at all. Then what is the consistency? Homogeneous or heterogeneous? And this was a relatively homogeneous. There was no cystic change, no calcification, no bleed, nothing like that in your case. Then look for the surrounding bone. Some scalloping in benign long-standing cases, it can cause a fossa formation. Means there will be scalloping of the smooth scalloping of the inner margin. In a malignant, you can see erosion and infiltration, destruction-like picture. Then hyperostosis, when there is a meningioma or something arising from the margins, you can get hyperostosis even. So exact location of the mass with a particular compartment and its relationship to the adjacent optic nerve, muscles, and what is its relationship to the orbital apex also to be reported. Then any extension outside the orbit into PNS or intracranial. Okay, this much should be there in the report. So I'll just show you a few images. This is a lacrimal gland tumors. Here you see this is a T1 weighted image. This lacrimal gland is seen in the upper outer quadrant. And this is a very smoothly marginated. So it's a benign appearing thing. This is a T2, somewhat heterogeneous. It is a fibrous solitary tumor. And this is a pleomorphic adenoma. You see, it is intensely enhancing. It is just indenting on the globe. There is no infiltration. And here you see it was a carcinoma. It was eroding actually. Here you see this sort of destruction. When you see, you have to think of a malignant thing. So the relationship to the adjacent structures, location, and the nature of bone erosion, all these things should come in the report. Next, when it's an eyeball tumor, when it is confined to the globe, it won't cause proptosis. A simple ultrasound can show. When there is an extra orbit ocular extension like this, it has gone into the retrobulbar space, infiltrated the muscles and optic nerves, it can push the orbit out. And this was actually a treated lymphoma. I don't know, later it came with an extra orbital lesion. Normally we see it growing inside the globe. Here it has grown into the retrobulbar fat. And this is a T2 weighted image, and this is a T1 weighted. You see again, it's an MRI. Here, this is a CT because the bone is white. Here the bones are dark and the globe is dark. But the muscles are enhancing, fat is suppressed. So it is a T1 post contrast with an enhancing lesion, mass lesion. And here this is a T2, no, because this is bright and there is no fat suppression, simple T2 weighted image. And this is again, there can be invasion from surrounding structures. Like PNS tumor can invade into. So the surrounding PNS should be assessed in all cases. And here it's a small child. Here the lesion is eroding into from the orbit, it is going out. From the muscle. It is eroding into the maxillary sinus. And sometimes benign things like mucocele can also present with proptosis. Here you see, these two are the MRI because the bone is dark. And this is a ethmoidal region. And normally a fluid means it will be very bright like this globe. It is a T2 weighted image. So if it is a simple secretion inside the sinus, it will be white like this vitreous. And it should be dark like this thing on T1 weighted image. Here the vitreous is dark, so it's a T1 weighted image. But here it is that signal has altered. That suggests that it is a chronic inspissated secretion because the water, when it goes on absorbing, the secretion becomes thick. There will be a signal alteration that brightness has reduced, has become dark. And you see the bone, it has been, this is not a sort of destruction you have seen in that lacrimal tumor. This long-standing scalloping has led to breach in the bone. So this appearance is like that of a benign tumor. This was a mucocele actually. And in optic nerve tumors, that can also cause proptosis. And here you see the nerve is seen very nicely. It's coming from the sheath. So this is a sheath tumor, meningiomas. When the nerve as such is not seen, it's arising from the nerve fibers, that is glioma. So look for the signs. Then vascular lesions. Vascular lesions comes under two headings. It can be a vascular neoplasm. Neoplasm is a tube that comes under tumors. Like hemangiopericytoma means it is arising from the vessel wall. And hemangiomas also, some people group it under vascular neoplasm. Malformation means there is a problem in the structure of the vessels. This comes under two headings. It can be a high flow or slow flow. Usually when the artery, it divides into capillaries and then that capillaries, from the capillaries forms the vein. So normally there is no direct communication between the artery and the vein. When there is a direct communication between the artery and vein, we call it as fistula. That happens in the carotid-cavernous fistula. When the ICA ruptures into the cavernous sinus, there is a direct communication between the artery. So there will be torrential flow. So it is a high flow vascular malformation. Slow flow malformation is when there is malformations in the capillary bed or in the venous side. It enhances very late. They are the slow flow malformations. Hemangioma, some people classify under slow flow malformation. So I'll show you the pictures. So this is a case of capillary hemangioma. Actually, that baby had a lot of stain, like port wine stain on the face and frontal region. And after contrast, if it is a fistula, very high flow, there will be intense enhancement immediately after injection of contrast. This has been taken as a late thing, that still there is only subtle enhancement going on. So this is a capillary hemangiomas are non-encapsulated, and they're usually extracorneal, seen around the lid, and it will be spreading everywhere. And they usually regress as the baby grows and enhances intensely, but enhancement is late. These are the normal picture we get in a capillary hemangioma. You see it is around the lid only. Mainly it is on the outside. When you look into the intracorneal space, it is all normal. And this is a adult with proptosis. Here actually, there was a lesion in the intracorneal space. You can see this is a T2 weighted image. See, the globe is white. So, and this is a T1 weighted, globe is dark. In T1 weighted image, this lesion is relatively dark. In T2 weighted, it is bright. Where this vascular, this hemangiomas are usually very bright on T2. When you look at a normal other neoplasms, they will be slightly dark, but this hemangiomas look very bright on T2. So this is a possibility that it can be a hemangioma. And when you do contrast, we can do in many ways. We can give a direct injection and take one phase, or we can inject and take various phases, starting from the arterial, capillary to the venous. We can take multiple phases in one go. We can take multiple phases. Then we'll show how this enhancement is progressing in the tumor. So here we see some puddling has started. When you go to the later phase, it is filling up slowly. This sort of picture you get in hemangioma. It's a cavernous hemangioma which is slowly filling up in the later phase. And that is usually encapsulated with a fibrous capsule, and it is seen intracorneally also. Then this is another thing. There are two different cases. Here you see it is a T2, very bright signal, means like a fluid it was. And here also it is bright, but it's slightly dull. In T1, instead of, if it was a water signal, it would have looked dark, but it is bright. There may be bleed inside the thing. This is a veno-lymphatic malformation. In veno-lymphatic malformation, you get, it is a deformed lymphatic system. That mainly you will get a fluid signal. It won't enhance like other vascular, venous or this thing. But usually this lymphatic malformation, there will be associated some venous malformation also. So they show a bit of enhancement, but not so intense. You can see here it is a pure fluid signal. Here also enhancement is not that good in some areas. That may be because of the lymphatic this thing. And next is orbital varices. It is something like our hemorrhoids. When the vessel wall is very weak, when some pressure is applied, when you stoop down or do a coughing or Valsalva, the orbital vein engorges. That is what is seen. See, superior ophthalmic vein this side and this side is so big. And in the normally, it is not seen at all. So it's a case of orbital varice. Then the chirotico-cavernous fistula is when there is a direct communication between the artery and vein, bypassing the capillary bed. That is a fistula, AV fistula. And here, in chirotico-cavernous, it's of many types. One, there can be a direct connection between the internal carotid artery and cavernous sinus. Because the artery is lying inside the cavernous sinus, there can be direct connection. That happens with trauma. When there is a skull base fracture or something, that injury can happen, the artery can flow into the cavernous sinus. Or there can be shunting between any branches, small branches of the ICA and cavernous sinus, or there can be shunting between the meningeal branches of the external carotid artery and cavernous sinus. These are all indirect things. These things which Dr. Ani was asking initially, this might require DSA for. And this is one example just to show you what happens when the carotid artery communicates with the cavernous sinus. This engorges this cavernous And these are the draining vein. The superior ophthalmic vein drains into the cavernous sinus, and this is drained by petrosal sinus. So what happens when there is too much of gush here? This could not drain. This dilates. So you can see very much dilated superior ophthalmic vein. Here also you see. This is an MR and this is a CT picture. You look at the bone. This is white. And the cross section you can see a dilated ophthalmic vein. More than 3.5 millimeter means it is dilated. And there is a engorged vein going into the. So this is an evidence that there is a caroticocavernous fistula. There's a few cases. This is a DSA where they inject directly into the carotid artery and see for the communication. And if the communication is seen, they can block it by using the coils, platinum coils or something. We can occlude the fistula site. And you can see here, this DSA, that's a digital subtraction angiography. Even the fine branches are very nicely seen. Unlike in CT or MRI, only the major vessels are shown. This much of resolution you will never get in the CT or MRI angiogram. So when you have to look for the indirect caroticocavernous fistula, a DSA is a must. And for treatment also. Like orbital metastasis, it's very rare. That is, in kids you can get from neuroblastoma, Wilms tumor. Then lymphoma, leukemia, myeloma, all these things. Lymphoma we have seen already now. It's like a homogeneous, well-defined masses of soft tissue density, which can show enhancement on contrast. It will not erode into anything, but it will go around everywhere, obscuring the details of the surrounding structures. And she was telling one deity for this is sarcoid. Sarcoid classically involves that uvea, uveoscleral cord, uveitis and lacrimal gland involvement, but it can also give rise to soft tissue masses like this. Then inflammation is another thing which can cause proptosis. Inflammation, you look at the sharp margins, everything is shaggy now. When there is inflammation, the whole sharp outline is gone. Just the orbital fat is very hazy. This is a T1 weighted image. So it's all shaggy. Margins of the muscle is shaggy. Uveoscleral coat is thickened. Even the preseptal space is thickened. After contrast also, you cannot appreciate that the fineness. You see, everything is shaggy. So this is, you can make out, because in others lesions we found everything to be very sharply defined. And subperiosteal abscess, these are some of the complications which can come. Cavernous sinus thrombosis, you see a filling defect in the cavernous sinus, can lead to empyema, brain abscess. So you have to see in all sections taking various things, idiopathic, all this pseudotumors, all this gives a similar picture. It can involve anywhere. It can involve the muscle, involve the globe, lacrimal gland, optic nerve, everything. Next is the thyroid ophthalmopathy. The difference from this thing is it is more sharply defined. You don't see that shagginess here. And it is sometimes very symmetrical. And the tendons are not involved. This is one thing you have to see. When the tendon is involved means that is due to inflammation. Here only the belly is involved. And there can be an increase in the intraorbital fat sometimes, lid edema, optic nerve will be stretched. You see it mainly tortures this intraorbital part. If it is stretched and tendon sparing, belly thickening, with sharp margins, think of thyroid. If it is shaggy, think of inflammation, infection, pseudotumor and all those things. Okay, thank you.
I think due to constraints of time, we'll go faster. Who's the next presenter?
Jessina.
Okay. So can you increase the Zoom time? Allika?
I think it will be more.
Okay, then tell.
I think we can we can cut short this and go on to the third session so that
okay, we'll cut
there
short
will be some
this.
representation.
Okay. Okay then.
Is it okay, Sandhya?
ട്രോമയും കൂടി പ്രസന്റ് ചെയ്യായിരുന്നു. അതിൽ കുറച്ച് എന്തെങ്കിലും സന്ധ്യക്ക് പറയാനുണ്ടാവും.
Okay, then we will short presentation of trauma and then move on to the third session.
Only
Anita.
5 slides.
Okay, Anita. Start.
Good morning, all. My name is Dr. Anita. I'm from Government Medical College, Thrissur. I'm second year resident there. I'm presenting a case of a 62-year-old male patient who came to our casualty after a bike versus pedestrian road traffic accident. His chief complaints were redness, swelling, and defective vision of right eye since the accident. He was conscious but very much agitated and poorly cooperative to examination. His vitals were stable. There was no evidence of injury to other systems other than eye. Coming to ocular examination, right eye vision was PL negative with ocular movements restricted in all directions. There was periorbital edema, ecchymosis of right eye, orbital margins poorly delineated due to tense edema, 360-degree subconjunctival hemorrhage, and chemosis. With presence of corneal edema, total hyphema. The IOP was low on digital tonometry. Examination of left eye was within normal limits with vision 612 improving to 6.6. CT of the orbit was taken and it showed rupture of right globe with orbital hematoma in the medial aspect of globe, both in the intracorneal and extracorneal aspects, with lens displaced into the vitreous, right optic nerve contusion, and fracture of floor of right orbit with herniation of fat and inferior rectus into the maxillary sinus. There was also fracture of lateral wall of right orbit and fracture of lamina papracia. My diagnosis is an open globe injury with blowout fracture of the right orbit. Thank you all.
Hello.
Yeah, Sandhya. Sandhya, you can go on to your slides. Okay. Sandhya, you can go on to your slides.
Share it. Just only 5-6 slides.
Okay.
This is just to show only CT is needed. What should be the pattern of evaluation? One is you have to see the number, location, degree, and direction of the fracture fragment displacement, and the demonstration of the detached bony fragments in the orbit or intracranial cavity. In the medial wall fractures, you can see orbital emphysema because the air will be leaking in. In the optic canal fractures, may be suspected if the patient is having severe this thing. So you have to look for all the margins. Then you have to look for the foreign bodies. Then evaluate the soft tissue, any muscle entrapment, hematoma, emphysema, globe injury, and ophthalmic vein and optic nerve. I'll just show a few pictures. That's all. This is the floor of the orbit fracture. You can see this is sagging into the, and this is the, here, this is the inferior orbital nerve canal that is also fractured here. In the medial wall fracture, you can see it's the weakest point, it's very easily fractured lamina papracia. The air will be leaking into the orbit. And this area is very important where you see this optic struct is easily fractured. It's a very thin one. So the orbital apex should be very nicely seen in every case. Thin section should be taken and seen. And here there's a small fracture, the lateral orbital apex. And this is a roof fracture. And here you see the floor of, so we have to see in all views to look for the site of fracture. This is a strut fracture, you can see, this is strut fracture. And you can take a 3D image. Okay, and this is the mesh. So the foreign bodies, the radio dense, you can see very. Okay, these things you will be knowing. I know you can continue that. This is an MR image I'll show you. Here you see this is a T1 weighted, this is a T2 weighted image. normal T2 weighted image. See, everything is bright. So the problem is there is a very subtle bleed here. It is not very nicely seen. So there is a way of suppressing the water signal in T2. So this might look like a T1, but this is actually a T2 with water suppressed. Then what happens? The bleed stands out. Toroidal bleed. This is a new sequence. So in MRI, you have to manipulate with the sequences. In CT, it is not. Okay, in carotid, all this have been said. Okay, then I'll stop. Thank you. It's time already.
Thank you, Sandhya, for the excellent presentation. Now, let us move on to the third session. OPGs, be ready. This is an interactive session. And Dr. Annie will be discussing cases and sharing pictures. And you have to make an attempt to answer.
Okay. So after hearing so many, everything is being repeated. So you have to answer. If you don't answer, it is a crime. Okay. And you need not read anything again for the exam. Everything is covered here once, twice, everything. So the duration, in addition to the imaging, the duration is very important when you evaluate orbital diseases. For inflammatory diseases, it will be presenting between 1 or 2 weeks. Orbital cellulitis in 1 or 2 days. And orbital tumors in children, this is very important to remember. Within 2 months, lacrimal adenocarcinomas, malignant tumors of lacrimal gland in 8 to 9 months. And if the duration is more than 1 year, lacrimal adenomas, pleomorphic adenomas, lymphomas, or cavernous hemangiomas can occur, may be present. And as I said, I always prefer a CT. And MRI is done when you want to rule out orbital apical lesions or intracranial extension. So now the first PG, Dr. Manna, are you there? So can you read the CT? Can you hear me? Okay. Any PG? What is this lesion which is marked there? Yeah. Okay.
Hello.
Yeah. So to which suture line is it attached? I can't hear you. Tell once more. Be fast.
Superficial dermoid.
It is a deep dermoid. To which suture line is it attached? Okay, I'll give you half a minute. After that, I'll answer. Yeah, which frontoethmoid suture. Okay. And you have to remove the whole the wall also, otherwise it will recur. And this is a superficial dermoid. So to which suture line will this be attached?
Frontozygomatic.
Frontozygomatic. Okay. And this patient came with swelling in the temporal area, and the CT scan revealed a small connection to through the lateral wall into the temporal fossa. So which dermoid is this? What is it named?
Dumbbell dermoid.
Okay, PGs are answering, no? Okay, it's a dumbbell dermoid. So classification of dermoids, I'll say lack of time. So it's superficial dermoid and deep dermoids. And dermoids can mimic a dash, an abscess. So usually they'll come after an IND and the wall will be left there, it will be recurring. How will you differentiate a dermoid from other cystic lesions? Sorry,
well defined.
Dermoid will have a thick wall. The other cysticercosis and all will have a thin wall. Okay. So what is this cystic lesion? Next PG, Grishma. Okay. No. Lipodermoid will have lipomatous tissue and it will be spread out. Okay. This is in the palpebral lobe of the lacrimal gland. So this cystic lesion is nobody can answer. It's a dacryops or a cyst of the lacrimal ductule. Okay. And how do you incise this cyst? What will be the incision direction of the incision? It is this direction towards to minimize damage to the lacrimal ductus. Okay. Okay. Next question goes to Anupama. I don't know who's answering. I can't see. So next question to Anupama. What is this? Read the CT. It's not very clear, but PG. Anupama is there. What has happened to the temporal bone? Temporal wall, lateral wall. Anybody can answer. I don't know where Anupama is. There is a soft tissue mass with a which is growing into the temporal bone, isn't it? So what is this lesion? What could it be? And histopathology. Sphenoid wing meningioma. There will be bone formation and bone destruction. Here there is more of bone destruction. No? There is no calcification seen. So histopathology was like this. Lots of eosinophils were seen. Lots of eosinophils were seen. What is the lesion beginning with that eosinophil name? Eosinophilic granuloma, which is a part of histiocytosis. What is a typical giant cell in eosinophilic granuloma called Threania? PGs, anybody can answer. What is a typical giant cell called? Giant histiocyte. Okay, it's an eosinophilic granuloma, which is quite common. And you should always take a body bone scan to rule out other lesions, lytic lesions in the other parts of the body. So what is the classification of histiocytosis? Any PG? Classification of histiocytosis. You saw one case, eosinophilic granuloma. What if it is multifocal? What is it called? And what if it is systemic? Okay. And what are the differential diagnosis of bone eroding mass in a child? So bone eroding mass in a child.
Rhabdomyosarcoma.
Sarcoma. Okay. Then eosinophilic granuloma, you saw one case. Then Sandhya showed cases. No? She said, I don't know if she showed a picture, but she said bone eroding mass in a child. Okay. It could be a long-standing orbital hematoma. Yeah. It could be a chloroma, leukemia, chloroma, neuroblastoma. Did we say neuroblastoma? Here, the child will be very sick when the patient gets an orbital secondary in a neuroblastoma. Whereas in other cases like rhabdomyosarcoma and even in leukemia, this orbital may be the first presentation. Okay. Then another lesion involving the bone is an Ewing sarcoma. Can be seen in children who are about 10 years old. Ewing sarcoma can affect the bone. Okay. So this child came with a history of trauma and we thought it would be an hematoma, but it was a solid tumor. And it was a primary neuroectodermal tumor of neuroectodermal tumor, which is a very malignant tumor in children. And so recurrent trauma in children, you should think about B. Recurrent trauma in children. Think of anybody. Recurrent trauma in children. Shaken baby syndrome. Okay. Shaken baby syndrome. Say yes or no if you can hear me. Okay.
Okay, madam.
Yeah. Okay. And this was again, just read the CT. Sandhya had just now showed again another CT like this, just now. Read the CT, somebody.
There is a coronal section showing a ill-defined mass in the mainly
It's
in
a
the
well-defined,
quadrant.
well-defined irregular mass. Okay. With what has happened to the bone?
Remodeling.
Remodeling. There is bone destruction, isn't it? Bone destruction is there, and you can see in the frontal lobe, it is extended to the frontal lobe, extended to the brain. Okay.
Okay.
So here, what is the plan of management? We just take a biopsy. We can't take out the whole tumor. We have to know what tumor it is. And that also was a primary neuroectodermal tumor, which is highly malignant tumor. Patient has expired actually. So this child came with a proptosis and a retrobulbar mass of 1 month, 2 months duration. So in any retrobulbar mass of short duration in children, you should do a what examination? I've already shown there, fundus examination. Okay. And what should you look for in the fundus?
Disc edema, any choroidal folds, or any lesions.
No, that will be pressure effect. Okay. In addition to that, secondaries of what should you look for? Leukemias. Okay. What are the features of leukemia in a fundus?
Chance of bleed is that like
superficial hemorrhages. Superficial hemorrhages. Then one specific spot. What is that spot called? Spot. One spot. Named after. Yeah, rod spots. Rod spots. Look for rod spots. Hemorrhages. Okay. Then if you're diagnosing a leukemia, either by fundus examination or peripheral smear, then do a peripheral smear also in all these retrobulbar tumors. And if they are positive, you can even avoid a biopsy. You can directly go on to chemotherapy. Okay. So leukemia, acute lymphoblastic leukemias can present in the orbit as orbital secondaries, and the bone marrow and smear and all may be negative. Later become positive. Okay. That you should remember. So what is describe this lesion? Classical description of this lesion. Bone, what has happened to the bone?
There is a subperiosteal abscess. Like,
there is a soft tissue lesion. You can't say it's an abscess, isn't it? Patient is having a corneal ulcer and lag of thalmos and all that, but there is a soft tissue lesion which is abutting on the brain. And what has happened to the bone? It has been punched out. Punched out lesions are seen in which case? Punched out lesion. Systemic condition in which punched out lesions are seen. No. Fungal, you get bone destruction. Punched out, like as if you're punching it out with a coin or something. Which is systemic condition of multiple myeloma, but localized. You can see lots of plasma cells there. So it's called a local plasmacytoma. Okay, this was a multiple myeloma, localized multiple myeloma, punched out lesions, never forget. You can also see such lesions in histiocytosis on the skull, coin-like lesions, localized multiple myeloma. So this man had come 1 month after, not 1 month, 2 weeks after a trauma. And what can you see in the CT? And there was not much pain or anything. There was pus oozing out of the suture line. And what can you see in the CT?
Foreign body.
Yeah, what foreign body? Wood foreign bodies are usually seen as only air pockets. It's not well imaged in CT or MRI. Okay, it's a wood foreign body. But another wood foreign body you can see here, that's a hyperdense lesion. So it depends on the density of the wood. If it's thick, thin, or if it is dry or wet. That is how you can see the wood foreign body. You just have to follow the path of the pus. Imaging is not really helpful in wood foreign bodies. Okay. So what is this sign called? The right CT. Come on, you saw so many now. Rehana.
Teardrop sign.
Yeah, teardrop sign. It is seen in
Blowout fracture of inferior.
blowout fracture, and there is inferior rectus entrapment also there. You can see the inferior rectus there. Okay. So this child came with an anophthalmos of the right eye after an injury with a cricket ball. Okay, so we should look for, what should you look for? Recent onset anophthalmos after injury. Look for ocular movements. You can see that there is inferior rectus entrapment. So, okay, now comes the questions. Pediatric floor fractures are called dash, and why? What is the other name for pediatric floor fractures? Yes, good. Kavya. Where is a Kavya is coming second year. White-eyed blowout fractures. Why is it called white-eye?
Because the eye will be quite, only the fracture will be.
Yeah, because it's a trapdoor fracture, the muscle only will be entrapped. Okay. There is no ecchymosis, no bleeding, nothing. Only the muscle will be inferior rectus is the most common muscle to be entrapped. What are the theories of mechanism of floor fracture?
Hydraulic mechanism and buckling.
Okay, this is always asked. Okay, buckling and the other one?
Hydraulic.
Buckling and hydraulic theory. Okay. And why is there vomiting and bradycardia in pediatric floor fractures? Only in pediatric.
Medial wall is in.
Medial in floor.
Bradycardia can occur in white-eyed fracture.
Why? Why bradycardia? Bradycardia means there is vagal stimulation, isn't it?
Oculocardiac reflex.
Oculocardiac reflex because the muscle is entrapped. Because the muscle is entrapped, and actually it's an emergency. You have to actually release the muscle very fast. Okay. The inferior rectus is the most common muscle involved. And which is the most common site involved in fracture floor?
Medial most part.
Medial wall. Okay. Good. And when is pupillary involvement seen? Muscle, the nerve to the pupil is going along the nerve to which muscle?
Inferior oblique.
Inferior oblique. In rim fractures, it is anterior, no? Or inferior oblique is anterior. So in rim fractures, what are the indications for repair?
If there is a in up gaze, down gaze, if there is along with the cosmetic discomfort, and if there is more than 2 mm.
More than 2 mm? What?
Enophthalmos.
That means the fracture is large. If there is large fractures, and also not for cosmetic. If there is muscle entrapment, large fractures, okay.
Yeah, in up gaze and down gaze.
Yeah, that means muscle entrapment is there. Not for cosmetic involvement, for diplopia. For muscle entrapment, that is an indication for repair. You do not repair every fracture. What are the materials used in repair?
Bone graft can be used. Iliac bone graft.
Bone graft is the best. Okay. Other allogenic materials which are used? Silicone sheet. Okay. Porous polyethylene or medpore implants can be porous polyethylene. Okay. Then one more metal. Which metal is used?
Titanium plates.
Titanium. Yeah. Why is titanium used?
It is inert and it doesn't cause
okay. It is inert and it can be bent. Okay. Fracture in adults. How is it different from fracture in children?
Because in children it is more bone are more cartilaginous, more malleable.
Yeah.
Second power.
It will be just a trapdoor fracture, but in adults it will be large fracture. There is tissue prolapse, so movement will be full, but it will be large fracture. So you have to repair them. Okay. So read the CT. There is abduction limitation and anophthalmos and total ptosis, and look at the CT where I have marked. What is that? Tell me. Anita.
Nasolacrimal duct.
No, the arrow should be little bit above. Nasolacrimal duct can't be seen in this posterior picture. It should be very anterior to see the nasolacrimal duct, isn't it? You can see the ethmoidal sinus. What has happened to the ethmoidal sinus? Tell we can't see you, no, you can be very courageous. What has happened to the ethmoidal sinus? There is a fracture of the ethmoidal sinus, isn't it? Is Anita there? Anita, second year PG. When you are in the casualty, if you see such CT, you should not miss it. Okay. And there is medial rectus entrapment because there is abduction restriction also. So what will you advise the patient? What will you advise the patient in the immediate few days not to do?
Avoid nose blowing. Avoid
Always,
nose blowing.
always when you suspect fracture. Here there is a floor fracture also, you can see. So avoid blowing the nose. Okay. So what is this cosmetic disfigurement that this patient is having? Kavya. In the inferior wall or lateral wall. There is a depression of the zygoma. The zygomatic prominence is not there. Okay. So there is a zygoma fracture. You can see that, no? Did you all see? When a patient like that comes, take a CT and rule out zygoma fracture. Okay. This field defect is most commonly seen in dash. Emin. Is there Emin? Are there no male PGs? All are females. Good. What is this field defect called? This field defect?
Inferior altitudinal.
I mean, okay. Which trauma, in which fracture is it more, in which, not fracture, okay. Which trauma is it most commonly seen? Lakshmi.
Roof fractures.
Okay. Fracture. It's seen in traumatic optic neuropathy. Why is inferior altitudinal defect more commonly seen in traumatic optic neuropathy? Anybody knows? First years we will not know. Sriniya. How is the dural attachment of the optic nerve? How is it affecting this inferior field defect? You all are not reading, I think. The optic nerve sheath is very closely attached to the dura superiorly. Okay.
Okay.
So just say at least yes when you hear me. So when there is a trauma to the optic nerve, that is the pile blood vessels in the superior part are torn more commonly than the inferior part. So that is why inferior field defect is more commonly seen. So which sinus is commonly, which blood in which sinus is an indication of traumatic optic neuropathy? This was already told by Dr. Sandhya. Just a recap.
Posterior ethmoid sinus.
No. Jasmine. Blood in which sinus is indicative of traumatic optic neuropathy?
Sphenoidal sinus. Sphenoid sinus.
Yes. This was a paper which was published in AIMS. Blood in the sphenoid sinus and traumatic optic neuropathy. Okay, so what are the mechanisms of traumatic optic neuropathy? There are 4 or 5. Can anybody tell me? Grishma. Anita. I can see Anita and Justina. Mechanisms of traumatic optic, at least one other than, what is the most thing you should not miss and you should say, most common thing. I don't know if it's most common. Can you say anyone? Anybody? Okay.
Usually the intracanalicula part is affected. So due to edema.
Due to edema. Okay. Then when do you do optic nerve decompression? When you see something,
any
what do you see? Bony spicule. That is not coming out of your mouth. Okay, bony spicule, edema, then we said one more, no? So many we
any
said.
hematoma.
Any hematoma, okay. Transmission of force, that itself is enough. If there is any injury to the temporal area, you should look for RAPD, okay? Any injury to the temporal area, because transmission of force can directly go to the optic nerve along the sphenoid. Shearing force of the optic foramen. Superiorly optic nerve sheath and dura attached pile with, yeah. Then hematoma. Okay, all these should be said if they are asking you. Now coming to inflammation. So what are the features CT scan picture in an orbit, in orbital cellulitis? What does that arrow show? What does that arrow show? Tell me. Yes, correct. Tell me. Fat stranding. How does this sign come? The septa in between the fat globules are inflamed. Okay. So the fat stranding is because of the septa which are standing out due to the inflammation. And you can see fussy borders of the muscles. And you can see what is that arrow, the first slide, first CT. What is that structure? Tell somebody what is the structure seen in the CT first. Yo, somebody is always saying superior slapsus. Superior slapsus is usually seen near the ethmoid. Never seen when there is no sinus adjacent to it. This is the lacrimal gland fossa, no? So what is that structure? The classic description. Lacrimal gland oblong enlargement. It is there in Kansky when I studied Kansky. That was second edition. So oblong enlargement of the CT of the lacrimal gland with fussy borders, irregular borders. Okay. And what is the second arrow? The second slide, CT scan. Second arrow in inflammation. And how do you differentiate it from thyroid ophthalmopathy?
Tendon involving myositis.
Tendon involving. Tendon involved. Okay. Thyroid, you don't see that. So what are the causes of preseptal cellulitis? You may not say this. 4 causes are preseptal cellulitis. Look for dacryoadenitis, dacryocystitis, audiolum internum, and sinusitis. Okay. So this is the thing that you are going on saying, diagnosing this. The directional proptosis down and out. And there is describe that CT finding. Arrow showing that CT finding. Somebody describe the CT.
It's an axial section. Axial CT section showing a soft tissue lesion.
Yeah.
In the medial wall, elevating
adjacent.
the.
Yeah. Okay. Well, what is the shape? It is classically described. You should always learn the classical descriptions. If when you say that, you will pass without any problem. Okay. It is a smooth dome-shaped swelling adjacent to the sinus, pushing the medial rectus laterally. Isn't it? Can you see that now? Smooth dome shape. Yeah. That is the superior abscess. Okay. Never miss that. In this case, the child was very sick and there was the orbit was full of pus. So it is an orbital abscess. So how do you differentiate between an orbital and a preseptal cellulitis? Jasmine, tell me. Tell, how will you differentiate orbital and a preseptal cellulitis?
The soft tissue opacity will be anterior to the septum in preseptal cellulitis.
That is only after you take a CT. In the casualty, how will you differentiate?
Okay. There won't be any vision. Vision is not affected in preseptal cellulitis, and the extraocular movements are normal.
Yes,
There
okay.
won't be pupil will be normal.
Okay. All that is a complication that you see. What is the first thing that you have to know? There will be proptosis in orbital cellulitis, no proptosis in preseptal cellulitis. Okay. What is the most common causative organs of orbital cellulitis in children? Kavya. Usually it arises from the sinuses. Okay. So most common is, you may not say, no, not staph. It is Haemophilus influenza. What is the classification commonly used for orbital cellulitis?
Chandler's classification.
Chandler's, good. What parameters should be daily monitored in orbital cellulitis? Second year PG should answer this. Kavya, vision, extraocular movements. Okay, fundus and all. Pupil. Okay. So this is a Chandler's grading. It may not go in this correct order, but all these are there, and daily monitor pupils and vision. So what is the, this patient had right proptosis. What is the sign which is being tested there?
Nafziger's sign.
Nafziger's sign. What is that sign also? From underneath you do, I think it's the Cox sign. What is the CT finding? Somebody be fast, otherwise. There is a mass in the upper medial orbit, isn't it? Upper medial orbit. And what do you see in the sinuses? Are the sinuses intact?
No.
The bone of the sinuses is absent. No, it's not only erosion. When you see this, where the walls of the sinuses are absent, you must ask the patient if he has already undergone surgery. He already had undergone FES. Okay, that is why the walls are so much absent. Not only because of the erosion. Okay, so this fungal elements were seen, and it was a aspergillosis occurring in young immunocompetent patients. This was an immunocompromised and ill patient with orbital cellulitis, raised intraocular tension, RAPD, pupil involvement, and sinuses. Here you can see the ethmoidal and the maxillary sinus involved. So it is called a pansinusitis. Pansinusitis. So always think of mucormycosis and look for orbital apex involvement, cavernous sinus thrombosis. The patient died 2 days after presenting to us in that condition. Okay, it's a very fast progressing, and you should refer to the ENT surgeon for a biopsy, endonasal biopsy at an earlier stage. So this patient presents a discharging sinus, and read the CT scan. Zygoma, what has happened to the zygoma?
Zygoma.
So somebody read the CT scan. What is?
It's a coronal
Yeah, there
section.
is a soft tissue mass and there's still bone. Yeah, coronal section. Bone. What has happened to the bone?
Zygomatic bone.
Bone destruction is. Yeah, destruction. Also, what could it be? So much bone destruction, discharging sinus. It is a tuberculosis. Okay, when you see such cases, think about orbital tuberculosis. This case is inferior orbital mass, which is hard, producing hypertropia. And I'm not telling it to diagnose only after the histopathology. Non-necrotizing inflammatory cells with Langerhans giant cells were seen. So, what is this? Anybody? This was also shown by Sandhya. Very common. You give systemic steroids for this for long term. Anybody? Time is fast moving. Okay, it's an orbital sarcoidosis. Okay. So tell me the CT finding in this CT finding. Sandhya has already shown this once, twice, I think. What is the CT finding?
Coronal section.
Yeah, coronal. It's not coronal.
First one is the axial section.
Axial, yeah.
Showing a mass in the near the ethmoid.
Upper orbit, yeah, and it's extending into the ethmoid. And what has happened to the bone? The bone near the orbit has been totally dissolved or excavated. It is not eroded, it's excavated. Actually, it's described as scalloped border of the inner table of the sinus. It's totally destroyed. And even the outer table has been destroyed, and you can subverting on the brain. Okay. And what is the description of this mass? How will you describe this mass? Upper inner masses should always include differential diagnosis of frontoethmoidal mucocele. Okay. So how do you describe this mass? Classic description.
Mucocele is usually cystic.
Yeah, cystic, soft, fluctuant, mildly tender. If you say this classic description, then they'll have a tendency to pass you. Okay. Soft, fluctuant, mildly tender. That description alone is enough. The differential diagnosis ethmoidal. Describe the CT. Is it a subperiosteal abscess? Yes or no? Subperiosteal abscess. Is it a subperiosteal abscess?
No, it's not dome shaped.
It is not dome shaped, and the whole bone is shifted, isn't it? The whole bone is shifted laterally, isn't it?
Yes.
Yeah. So this is a ethmoidal mucocele. Okay. It is not a subperiosteal abscess. So what is the developmental order of this nasal sinus? Which sinus develops first? And which the last? Can anybody say? Jessina. Anybody knows? No.
No.
Ethmoidal sinus at birth can be seen. Maxillary sinus 7 years of age. And frontal sinus 12 years of age. So when a neonate comes to you, don't diagnose frontal sinusitis and ethmoidal mucocele. Not frontal mucocele. Okay. 12 years for the frontal sinus to develop. So this patient came with a boggy mass which is non-tender. Syringing was free, even though the mass was in the lacrimal sac area. What is the lacrimal sac area? Is it above or below the medial pectoral ligament?
Below the medial ligament.
Yes, below. Below, always think about lacrimal sac, and above, don't think about lacrimal sac. Okay. So, and syringing was free. And CT scan showed this picture. Can anybody say what has happened to the nasolacrimal duct? And what can you see? What else can you see? In addition to the mass. You can see the nasolacrimal duct. It is enlarged and the mass is extending into the nasolacrimal duct. And what can you see inside that white spot? What is that? Calcification. Okay. In the nasolacrimal duct. And in such cases, what should you, which other consultant should you consult? An ENT. What was this diagnosis? What was this? History of bathing in ponds was there in childhood. Rhinosporidiosis. Yeah, okay. Rhinosporidiosis. Seen less frequently now, but always in mind. Why is the syringing free in rhinosporidiosis and in lacrimal sac tumors? Syringing is free. Why?
It's not obstructing.
Yeah, it is not obstructing the nasolacrimal duct. Okay. It is just present there in the sac. So the fluid will flow all around the mass. Okay. Case of migrating edema, recurrent attacks with the residual mass. Think about which is the most common worm to be seen in such conditions?
Dirophilia.
Yeah, very good. Who said that? Who said that?
Emin.
Okay.
Emin.
Emin. Okay. Emin is a female, no? Okay. Down and in proptosis with a well-rounded mass. I'll tell you in the lacrimal gland fossa. What will be this diagnosis? The duration was more than 1 year.
Pleomorphic adenoma.
Pleomorphic adenoma.
Very good. Very good. Pleomorphic adenoma. You're getting better than me. This case, I'll tell you the CT finding. There is a mass in the lacrimal gland fossa, which is extending beyond the midline and below the lateral papillary ligament. And what do you see in the bone? Tell me that. What do you see in the bone? Excavation or erosion? What is the bone? The both erosion, and more than erosion, there's an excavation, then followed by erosion. That means it was a benign tumor first, and then it has become malignant. Okay. So bone erosion, calcification crosses the midline in coronal section, goes below the lateral papillary ligament. You should think of a malignant tumor, which is adenocystic carcinoma. And tell me the CT finding in this.
Thank you.
Extensive bone destruction you can see, no? So what is the current modality of treatment in adenocystic carcinoma?
Can give radiotherapy.
Radiotherapy is last. First take a biopsy.
Yes.
So in this case, you cannot remove the whole tumor. It's extending to the temporal fossa also. So just take a biopsy and then you give. You have to reduce the tumor by chemotherapy. When after you reduce the tumor, you do en bloc dissection.
We can excise en bloc.
En bloc dissection, including the bone. Just one more slide. I don't. So duration different lacrimal gland tumors. Now you know, no? How you can diagnose the different lacrimal gland tumors. Pleomorphic adenoma, lymphoma, and adenoid lymphoma will be more than 1 year duration. Adenoid cystic carcinoma, you will it will present in 6 to 8 months. Okay, and inflammations, orbital cellulitis, lacrimal gland enlargement will be less than 2 months. Adenitis. A sign you should not miss in malignant lacrimal gland tumors. Perineural invasion. Okay. So how do you diagnose perineural invasion? In all lacrimal gland tumors, look for sensation. Sensation. Where? Sensation where? Where is the lacrimal gland?
Supratemporally.
Temporally. Supraorbital temporally. Okay. Current modality we already said. So that is the slide. En bloc dissection of removal of the bone has been done. Okay. Did you see that? And radiotherapy has been given. Always give radiotherapy to the lacrimal gland fossa, either by brachytherapy or external beam radiation after you excise adenocystic carcinoma. Otherwise, it will recur. So this is a left lacrimal gland mass of more than 1 year duration. And what do you see there particularly? The lacrimal gland is perpendicular to the lacrimal orbital margin. So that is a sign of lymphoma in a lacrimal gland. Okay. Lymphoma. Bilateral lacrimal gland masses. What are the differential diagnosis? Time is running out. Lymphoma. Tell me at least one. Lymphoma. Okay.
Lymphoma.
Then
metastasis.
Bilateral.
Metastasis.
Metastasis in lacrimal gland, it won't come. It will be retrobulbar. And retrobulbar bilateral, the metastases are usually not retrobulbar, it is choroidal. Choroidal in the adult. Okay. Choroidal is bilateral. Bilateral lacrimal gland masses along with submandibular gland enlargement. Where do you see?
Sjogren syndrome.
Yes. Good, good, good. I will tell the rest. Otherwise, there is no time. Sjogren's, lymphoma, you said all this. Tuberculosis can occur bilaterally. Sarcoidosis, you should think about vaginous. Okay. And orbital cell, idiopathic orbital inflammatory disease. That is a new name for pseudotumor. Don't say pseudotumor. It's called idiopathic orbital inflammatory disease. So this is again, what is the CT finding? Classical description of this CT finding. Molding mass, molding along the muscles, molding along the subconjunctiva. Okay, molding mass is the lymphoma. What is this classical subconjunctival mass called in lymphoma?
Salmon patch. Salmon.
Very good, salmon patch. Salmon is a fish, so fish flesh appearance. So what is the most common extranodal form of lymphoma in the orbit which is seen?
B-cell lymphoma.
Yeah, B-cell Malt lymphoma. What is the outline treatment for orbital lymphoma and systemic lymphoma? Just one sentence. Chemo in systemic lymphoma, orbital lymphoma, just radiation. Okay. So all that we have covered. So that is a patient who had a orbital radiation. It just melts on orbital radiation. Mild dose of orbital radiation is enough. Okay, that is. So this patient came with a well-defined mass in the medial orbit, huge one, and vascular channels surrounded by pericytes were seen. So this tumor is called?
Cavernous hemangioma.
No, pericytes.
Hemangiopericytoma.
Very good. Or it's also now called solitary fibrous tumor. It's a hemangiopericytoma. This was a well-encapsulated mass producing gross proptosis. It is seen in the abdomen and other parts of the body also. You may not say this. It is a fibrous. Did it come? No.
Different.
Fibrous histiocytoma. Okay.
Hemangiopericytoma and solitary are different. No? This is the same thing.
It's called hemangiopericytoma new, or is fibrous histiocytoma also included in solitary fibrous tumors?
Right.
I think the new thing, yeah. So all these tumors I kept just because you can say the differential diagnosis of any orbital solid tumors. You can say hemangiopericytoma, schwannoma, solitary fibrous histiocytoma. All these can be said in the differential diagnosis. This was a huge tumor in the upper medial orbit producing bone. What is seen in the bone? Excavation or erosion?
Excavation.
Okay, be fast. Otherwise, I won't cover everything. What is the characteristic histopathology in schwannoma?
Anthony.
Anthony. Who said that? Anthony, is the spelling correct? Spelling is A-N-I, not E, not Y. Okay. Anthony B and Anthony A. Okay. This patient had a squamous cell carcinoma of the vocal cords and secondary cerebrobulbar tumor was seen unilateral. Okay. So recent onset of enophthalmos. What should you think about recent onset of enophthalmos other than trauma?
Montgomery syndrome. Atelectasis of the maxillary sinus.
Okay, that is a good thing. Sunken sinus syndrome. Yeah, I didn't expect you to know that, so I didn't keep that. Another one. What secondaries can produce enophthalmos? Okay. Secondaries from dash and dash can recent onset enophthalmos. Scarus carcinoma of the breast and stomach. Okay. And I think orbital secondaries, no primary detected in more than 1/4 or more than half. So squamous cell carcinoma extending to the orbit. That was a diagnosis in this patient. So what will you advise? What is the surgery which to be advised in this case? Jessina.
Excineration.
Good. So what after excineration, what can you, what type of prosthesis? Two different type of prosthesis that you can give. Stick-on or spectacle mounted prosthesis. Okay. Oh, I'm just reaching the vascular lesions. Okay, so this patient had a long-standing proptosis, which slightly increased with pregnancy, and this was diagnosed as a cavernous hemangio. You can see the lesion, which is very encapsulated, retrobulbar, and it is common in which group of people?
Middle-aged group.
Middle-aged females. Okay.
Female.
Why does it not enhance much with contrast? Because there are caverns, with the vessels. Okay, there are cavernous spaces filled with RBC. And what are the other tumors which increase in size during pregnancy?
Meningioma.
Meningioma, good. Meningioma, then neurofibroma also. Okay. It is easy to excise. What are the indications for removal and what is the dreaded complication during removal in retrobulbar tumors?
Hemorrhage.
Not hemorrhage. Optic nerve. Yeah, optic nerve. There can be defect, the vision loss after, because it is sitting on the optic nerve, retrobulbar tumors. And this is, it can occur in the periphery also. Okay. And okay, this child, this girl had a this thing, increase in proptosis with delivery, and fundus examination, look carefully in the fundus for macular folds, and this was a retrobulbar tumor. And what are the indications for surgery?
Vision threatening.
One, if there is a vision loss or there is a recorded increase in size. Okay. Otherwise, if you do surgery, sometimes you can compromise the blood circulation of the optic nerve. So you can record an increase in size and tell them to come every 6 months. So what is this well-enhancing lesion seen in children?
Capillary hemangioma.
Capillary hemangioma diagnosis is that it enhances well because of the blood supply. Okay, so what is the natural cause of capillary hemangioma?
It regresses by 3 to 7 years.
7 years, okay. Now, what are the treatments recommended now?
Timolol eye drops can be given.
Timolol eye drops, timolol gel onto the lesion. Okay. Okay, then?
Carbon dioxide laser
can be given. Yeah, then?
Propranolol. Tablet. Systemic propranolol.
Yeah, that is what I wanted. Systemic propranolol produces a very gross reduction in the lesion if it's given early also. But it plateaus after some time. Then you can do what? After it plateaus.
Excision.
No, excision if it is localized. Or you can give a injection of
embolectomy.
Not embolectomy. What injection can you give into the lesion?
Triamcinolone steroid.
Triamcinolone. Good. Triamcinolone and betnisol can be combined and given. Okay. And what are the indications for treatment in lid capillary hemangiomas?
If it is amblyopia, causing amblyopia and isometropia.
Or astigmatism. Always check for astigmatism after dilating CTC in capillary hemangioma. What is one syndrome which is associated with capillary hemangioma?
Kasabag-Merritt syndrome.
Kasabag-Merritt in large hemangiomas due to sequestration of platelet. Okay. So what is this CT finding? Huge proptosis, long-standing. Oh, I forgot to obliterate the face. Okay. There are multiple cystic lesions inside, no? Okay. Can you see? And you can see calcification also. It's a lymphangioma. And you have to diagnose a lymphangioma mostly from the CT. And here what do you see? Multiple cystic levels, fluid levels. And a subconjunctival hemorrhage. So that is also a lymphangioma. Don't miss the diagnosis. So what are the different radiological and histological types of lymphangiomas?
Superficial and deep.
Different radiological types. Cyst. What are the different types of cysts that you get in lymphangiomas? Microcyst and macrocyst. Okay. Microcystic and macrocyst. Bleeding into the lymphangioма is called
chocolate cyst.
Yes, chocolate cyst. Symptom which the patient will give you a clue to the diagnosis of lymphangioma.
Bluish discoloration while crying.
Okay. Then symptom. When the patient gets fever, what happens?
Increase in size.
Increase in size. That you have to ask for, otherwise they may not know. Okay. That is a symptom which you can. Is it easy or difficult to remove?
Difficult.
It is the most difficult tumor to remove. Why? Because it is not encysted.
Not
It will grow around all the vital structures. So, what is the current modality of treatment? It is not excision anyway. So, what is the current modality of treatment? A very cheap modality. Okay, nobody knows. Injection bleomycin into the lesion. Okay. 2 injections will reduce it's an antibiotic and it will reduce the anti-inflammatory, which will reduce and you can also give injection local steroids and systemic steroids, which will reduce the lesion. Okay. Sclerosins. So what is this lesion? Tell me, what is the patient doing?
Capillary hemorrhage.
No. What is the patient doing? Valsalva manure. So what increases in Valsalva manure?
Orbital varices.
Orbital varices. Okay. Orbital varices. So what is the CT finding? What is the CT? It's not very clear CT. What is the arrow showing? What is that arrow, doctor? Superior ophthalmic vein. Yeah, superior ophthalmic vein is enlarged, isn't it? The most frequent presentation in orbital varices is proptosis or anophthalmos?
Intermittent proptosis.
Intermittent proptosis, or patient will come with you with anophthalmos only when you tell the patient to do Valsalva manure. So calcification in the orbit is seen in which other conditions?
Meningiomas.
Meningioma. Lymphoma, no. Lymphangioma you saw now. So
varices.
Orbital varices. Then is there any other? Adenocarcinoma, I think. Adenocarcinoma of the lacrimal gland. You can see bone destruction, calcification. Okay. What special request should be given to the radiologist?
To take CT
scan should be done with Valsalva. Otherwise, you may not see any lesion. Okay. See the difference with Valsalva and after and before Valsalva. This is usually hemangiomas are coexisting. It's a we know lymphatic malformation. Orbital varices can coexist with the hemangioma. So here, what is the prominent? What does that arrow show?
Superior ophthalmic vein.
What is that arrow? Yeah, which goes from the medial to the lateral side. Anteriorly, it is medial and then it's lateral. And abduction will be restricted. Why is abduction restricted in this case?
Okay.
What is the diagnosis here?
Keratoconus fistula.
Why is abduction restricted? Why is abduction restricted?
Due to
Sixth nerve is involved. Sixth nerve is involved. Why?
As false localizing sign raised intracranial pressure.
No. It is no, intracranial pressure is not at all raised. The pressure is raised only in the cavernous sinus. It is because the sixth nerve is closely related to what in the cavernous sinus?
Internal carotid artery.
Yeah, that is why. Okay. So, what are the different entities of keratoconus fistula?
Direct and indirect.
Direct and indirect, high flow, low flow. Okay. Yeah. What will be the presentation in indirect? Direct, you all know. Indirect, periodical cavernous fistula. When the small vessels open into the meningeal vessels open into the cavernous sinus.
It precipitates on minor straining.
Okay, when bending down for a long time, then unilateral glaucoma. Okay, when there's unilateral glaucoma, you should always think about this finding. Okay. Hello.
Okay,
Nobody. Yeah. Unilateral glaucoma. And unilateral extraocular muscle enlargement. And unilateral venous congestion in the fundus. Fundus finding will be unilateral venous congestion. Think about this, okay? What is the anterior segment finding in keratoconus fistula?
Corkscrew vessels.
Anterior segment finding will be, there will be anterior segment ischemia. Okay, what all the findings of anterior segment ischemia may be there. Corkscrewing of vessels are there in the conjunctiva. Anterior ciliary vessels may be enlarged, but anterior segment there can be anterior segment ischemia. Okay, which nerve is more commonly affected? We said. Read the CT. Jasmine. Patient is coming with unilateral proptosis of long standing. If anybody is telling, I will give you a chocolate. Jasmine, Jessina, Anita.
Postromedial
mass. Mass. Okay. Anybody knows the correct answer? Long-standing proptosis, right eye. Nobody saying no. No chocolate. It is a posterior staphyloma. Okay.
Okay. Okay.
Did you all understand? It is the globe only. It's enlarged and thinned out. So that also it's a case of pseudoproptosis. Okay.
Okay.
I finished. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Okay. So now you need not read about proptosis. You know everything, no? Sujata?
Yes. It's a wonderful
There are some
presentation.
questions, Ani and Sandhya. There are some questions on YouTube.
Okay.
Sandhya, what are the characteristic features of orbital melanoma on CT and MRI, and why does melanin cause these features?
Melanin causes it is normally tumors are dark on T1 and bright on T2. This melanin causes T1 shortening, that it causes a change in that relaxation time. So in T1, this melanomas will look bright. Normally, most of the lesions are dark on T1.
Dr. Ani, is a surgical intervention or exploration required for a 10-month-old fracture of floor orbit with an orbital fat herniation, which is very mild?
You can, if there is orbital, if there is movement restriction in babies, it is a baby 10-month-old child. Elevation will be restricted. So elevation is usually bilaterally restricted in neonates. So you will have to do a force reduction test under GA. And you can, if it's a very mild thing, you can just pull it out. Actually, the tenons, the muscles, the muscle will not be interrupted. You can just pull it out and then later see. You can give a local anesthesia there along the muscle, because otherwise you will stimulate the vasovagal stimulation. So just with a large tooth forceps, after giving a block, just do a force reduction test, which is therapeutic also.
And how do you say floor fracture is large? Is there an objective cutoff?
If the anophthalmos, they say if the anophthalmos is more than 2 millimeters. But usually when the patient is presenting in as an adult, there will be chemosis, and you cannot measure the proptosis objectively. In adults, usually the fractures are large, so we advise repair. Otherwise, later on, it can develop in an ophthalmos.
And what do you do for orbital emphysema following fracture? Is there a role for aspiration of air?
No, you just have to give a sedate. You can sedate the patient a little and give a pressure pad. Tell them not to blow the nose again, and it will go off in 1 or 2 days.
These are the questions. Radha?
Yeah.
We have left out. We both of us didn't cover the ultrasound findings in orbital, in choroidal melanoma, retinoblastoma, and all those. So choroidal, that is very important. So choroidal melanoma, and you can tell them to read. Now time is over. Ultrasound findings. Okay.
So we'll find a session before that. Thank you, Dr. Sandhya, on my personal behalf and on behalf of all members of the Thrissur Ophthalmic Club for agreeing to for this presentation and for your excellent and exhaustive presentation about basics of CT. CT and MRI and ultrasound. As someone said, you have made it so simple. And also, I thank you for sharing all the varied collections of images in the important aspects, important clinical conditions like proptosis and trauma. So I thank you again, Sandhya. Now I thank Dr. Anishrithar for giving valuable suggestions in planning these sessions and also chairing this workshop, and also for the your very clinically informative and coordinated presentation, third session. I am sure that all our PGs have not only understood how to read the presentation by your first 2 sessions and how to clinically coordinate, and also to understand everything about orbit, I think, by your presentation. Thank you so much, Annie. Then
actually, I'm surprised they answered so much.
Yeah,
there is some secret.
Usually they don't.
They are getting better soon.
Yeah.
Now, I thank all the postgraduate students for their wonderful participation, and I'm sure they have benefited from it. Also, I thank all the senior faculty like Dr. Babu Krishna Umar, Dr. Andrew Sir, and all others for their participation. Now, I would like to thank Dr. Bastian and Dr. Tanu for their technical support. And finally, I would like to thank KSOS and Dr. Rajesh Sugumaran sir for providing this wonderful Zoom platform, KSOS platform. I thank you everyone again. Thank you all.
Thank you.
Thank you.